amanah Presiden, ini saya ambil dari paparannya Pak Menteri Kesehatan, yaitu ada 3 hal yang harus dilakukan oleh Kementerian Kesehatan di era Pak BGS ini, yaitu adalah vaksinasi secepat mungkin. Alhamdulillah sudah bisa kita laksanakan. Selain vaksinasi COVID, Puskesmas sekarang dikejar oleh BIAN, kemudian vaksinasi kanker serviks. Ya, ini tidak mudah untuk memanage tenaga, terutama adalah tenaga medis, paramedis, dokter, perawat, dan bidan. Kemudian mengatasi pandemi dengan berbagai program dan inisiatif untuk mengendalikan COVID. Alhamdulillah COVID sudah melandai dan mudah-mudahan ini tetap terus bisa kita kendalikan sehingga ekonomi bisa segera bangkit dan kita bisa beraktivitas seperti semula. Kemudian yang ketiga adalah transformasi sistem kesehatan untuk memajukan masyarakat Indonesia yang sehat dan kuat. Ya, ini 6 transformasi di bidang kesehatan. Saya mengambil adalah transformasi di layanan primer. Kemudian saya kaitkan dengan transformasi sumber daya manusia kesehatan. Karena transformasi di pelayanan primer ini tidak bisa lepas dari transformasi kelima. Transformasi pelayanan primer yaitu di edukasi kesehatan, pencegahan primer, pencegahan sekunder, kemudian peningkatan kapasitas dan kapabilitas layanan primer yang akan kita dukung dengan transformasi di bidang kesehatan. Ini kalau kita lihat transformasi layanan primer, endingnya adalah semua orang bisa memiliki akses yang mudah ke layanan primer. Ya. Kalau zaman dulu kan akses biaya, akses jarak, akses tenaga. Nah, ini semua orang memiliki akses yang mudah ke layanan primer. Akses ini bisa berbagai hal ya, dari segi pembiayaan sehingga ada sistem pembiayaan, kemudian akses dari jarak bagaimana kita mendekatkan layanan, kemudian akses dari pelayanan bagaimana masyarakat itu datang ada nakes yang melayani ya. Kemudian nakes layanan primer meliputi imunisasi, konsultasi dokter umum, pemeriksaan kesehatan, edukasi masyarakat mengenai pola hidup sehat. Jadi masyarakat datang ke puskesmas atau ke vaskes itu tidak harus sakit. Ya, ini paradigmanya dulu kan datang ke vaskes itu harus sakit. Ya sekarang enggak, masyarakat datang ke vaskes, ketemu tenaga kesehatan, ini untuk konsultasi kesehatan bagaimana dia mewujudkan kesehatan diri dan keluarganya. Kemudian revitalisasi struktur dan jejaring layanan kesehatan primer ini juga harus diikuti dengan transformasi di bidang Labkesda. Revitalisasi struktur dan jejaring Yankes, bagaimana kita mengintervensi layanan primer ini dalam satu siklus kehidupan. Ya, ditekankan pada bagaimana memelihara kesehatan, mewujudkan kesehatan, paradigma sehat, bagaimana masyarakat harus sehat supaya tidak sakit. Sehingga kalau kita lihat tadi di dasar hukum adanya Impres nomor 1 tahun 2017, bagaimana seluruh kekuatan yang ada di pemerintahan ini berkontribusi mewujudkan masyarakat hidup sehat. Dinas pendidikan harus bagaimana, pariwisata harus bagaimana, ketenaga kerjaan harus bagaimana, kemudian kesehatan sendiri harus bagaimana. Jadi tidak semua begitu ada kalimat sehat, itu urusannya orang kesehatan. Nah, paradigma ini harus dirubah sesuai dengan Impres nomor 1 tahun 2017. Siapa berbuat apa untuk mewujudkan masyarakat Indonesia, masyarakat yang sehat, masyarakat yang kuat. Dalam pemenuhan kebutuhan dalam siklus kehidupan ini diperlukan standarisasi layanan sesuai dengan kebutuhan dalam satu siklus kehidupan, kemudian optimalisasi edukasi dan pemantauan kesehatan masyarakat, kemudian penguatan upaya preventif dengan pelayanan yang komprehensif. Kemudian penguatan di jaring layanan Labkesda di setiap tingkatan, baik untuk diagnostik dan surveillance. Jadi pelayanan laboratorium kesehatan ini tidak hanya untuk kesehatan, tetapi kita harus meningkatkan bagaimana lab tersebut mempunyai fungsi di dalam penguatan surveillance ya, di daerah terutama. Perlunya standarisasi dan integrasi fungsi laboratorium kesehatan masyarakat di setiap tingkatan, kemudian penguatan surveillance penyakit dan diagnostik, kemudian pengelolaan bioresponsibility tentang spesies penyebab penyakit. Artinya surveillance ya, ini surveillance harus kita kuatkan. Sekali lagi, tidak hanya untuk memeriksa, tetapi lab ini dikuatkan kepada lab surveillance. Ini gambaran satu siklus kehidupan saja, bagaimana kita mengintervensi dalam suatu siklus kehidupan dengan menekankan upaya promotif preventif. Kita tidak bisa terkotak-kotak karena manusia ini hidup di dalam satu siklus, sehingga program-program yang dilaksanakan ini harus selalu memperhatikan siklus kehidupan manusia ini. Kemudian bagaimana sih kebutuhan tenaga di layanan primer, atau kalau kita lihat di transformasi sumber daya manusia kesehatan, endingnya adalah bagaimana sumber daya manusia kesehatan ini harus cukup dan merata di seluruh Indonesia. Jangan sampai hanya terpusat berkumpul di Jawa, tetapi di luar Jawa yang sangat memerlukan uluran tangan kita ini kekurangan tenaga, sehingga pemerataan di seluruh Indonesia. Ini saya ambil dari paparan Pak Menkes, bagaimana tadi kita mewujudkan layanan primer, ya, layanan primer. Jadi kalau kita lihat di paparan Pak Menkes, angka 52 ini ya, tadi kita lihat PMK 43 tahun 2019, bahwa puskesmas ini bertanggung jawab terhadap kesehatan primer dengan mengutamakan promotif preventif. Yang mengerjakan siapa? Kolaborasi seluruh stakeholder. Tetapi realita yang ada saat ini, 52% puskesmas ini belum memiliki 9 jenis tenaga kesehatan dasar. Ini dasar, 9 jenis tenaga dasar. Ya. Nanti akan kita lihat 9 jenis tenaga kesehatan dasar yang harus ada di puskesmas ini apa. Jangan sampai kita tidak mempunyai pola, kita mengangkat tenaga macam-macam, tetapi 9 jenis tenaga dasar ini tidak terpenuhi. Sehingga di dalam Renstra, contohnya di tempat kami, kami masukkan di Renstra Dinas Kesehatan bagaimana pemenuhan puskesmas terhadap 9 jenis tenaga dasar. Sehingga kalau kita rekrut tenaga, analisis beban kerja, analisis kompetensi, ini harus melihat mana yang prioritas. Ya. Jadi kepala puskesmas dengan manajemen puskesmasnya harus memahami ini. Ya. Kemudian 6% nih puskesmas belum memiliki dokter, tetapi yang 52% ini ya 52% ini puskesmas belum memiliki 9 jenis tenaga kesehatan dasar. Kemudian apa upaya-upaya yang harus kita lakukan? Kalau kita lihat di PMK 43 tahun 2019 tentang pusat kesehatan masyarakat, 9 jenis tenaga yang ada adalah dokter gigi, perawat, bidan, tenaga promosi kesehatan, sanitarian, nutrisionis, apoteker atau tenaga teknik kefarmasian dan ahli teknologi laboratorium medik atau TLM. Kalau dulu tenaga promkes mungkin banyak tenaga yang ada, promkes tidak ada, nutrisionis tidak ada, kan seperti itu. Ya sekarang ini dasar nih, apalagi sekarang masalah kita adalah stunting. Kenapa tenaga promkes ini harus ada? Sekali lagi, bagaimana promotif preventif ini menjadi lebih dominan daripada upaya kuratif dan preventif. Sehingga teman-teman dokter gigi, perawat, bidan, ini bicaranya juga sudah bagaimana pencegahan. Bagaimana pencegahan ini dilakukan supaya tidak sakit. Jadi mungkin perawat, seperti itu. Paradigmanya tidak hanya merawat orang sakit, ya seperti itu. Kemudian dokter tidak hanya mendiagnosis, ya. Bagaimana harus dilakukan edukasi kepada masyarakat dalam menjaga derajat kesehatannya, dalam menjaga kualitas hidupnya. Kemudian tenaga dasar ini juga harus didukung adanya tenaga non kesehatan. Tidak mungkin suatu organisasi ini hanya ada tenaga ini ya, tenaga dasar ini ya. Tapi 9 tenaga dasar ini menjadi utama. Tenaga non kesehatan contohnya adalah karena ini organisasi, berarti ada proses administrasi, ketatausahaan. Kemudian itu adalah organisasi, di situ ada anggaran, pasti butuh tenaga keuangan, ya. Tapi yang ada saat ini banyak tenaga-tenaga bidan, perawat, prokes, sanitarian, nutrisionis ini dibebani juga oleh keuangan dan ketatausahaan. Ini yang harus pelan-pelan kita selesaikan. Sehingga tenaga-tenaga kesehatan ini bisa menjalankan fungsinya sesuai dengan profesinya. Tidak nanti justru pekerjaan tambahan ini menjadi besar. Ya, ini yang terjadi di Puskesmas saat ini kan banyak pekerjaan tambahan yang kadang-kadang justru melebihi pekerjaan pokoknya. Ini kalau saya di Kota Solo, ini pelan-pelan ini harus kami hilangkan, harus kami perbaiki. Bagaimana kita kembalikan teman-teman profesi ini kepada profesinya, karena profesi ini sangat dibutuhkan di dalam menyehatkan masyarakat. Kemudian sistem informasi dan kegiatan operasional lain. Ini minimal. Nah, kemudian dalam keadaan tertentu, puskesmas tersebut sudah berkembang, pasiennya banyak, puskesmasnya di perkotaan, kemudian permasalahan kesehatan ternyata sangat kompleks. Ini diperlukan penambahan tenaga, sehingga perlu dilakukan analisis kebutuhan tenaga. Ya, dalam kondisi tertentu, puskesmas bisa menambahkan tenaga terapis gigi dan mulut, epidemiolog, kemudian entomolog, perekam medis dan informasi kesehatan, dan tenaga kesehatan lain sesuai dengan kebutuhan. Ya, sekali lagi ini harus dihitung dengan analisis beban kerja. Berapa sih puskesmas itu butuh perawat? Apa sih tugas perawat di puskesmas? Perawat di puskesmas ini tugasnya tidak hanya di dalam gedung, dalam BP, tetapi bagaimana perkesmasnya harus jalan. Kemudian bagaimana harus perawat ini melakukan kegiatan sebagai koordinator saat P2. Bagaimana kegiatan ini harus dilakukan. Ya, jadi harus kita menghitungnya, oh saya butuh dokter 2, saya butuh perawat 4, saya butuh bidan 4. Hanya berdasarkan keinginan, ini enggak boleh. Ya. Tetapi harus dihitung berdasarkan analisis beban kerja, ada PMK-nya yaitu PMK 35. Ya. Bagaimana sih teman-teman puskesmas menghitung kebutuhan tenaga? Ya, ini saya bicara fokusnya di pemerintahan ya puskesmas. Tapi sekali lagi PMK 43 mengamanahkan bahwa puskesmas ini adalah penanggung jawab wilayah. Kegiatan-kegiatan ini kita harus berkolaborasi dengan vaskes non pemerintah, apalagi di era JKN. Sehingga vaskes non pemerintah di luar puskesmas, mungkin dokter praktek, dokter gigi praktek, klinik, ini bukan pesaing, tetapi ini justru kekuatan puskesmas. Sehingga teman-teman di pelayanan primer non-pemerintah ini juga harus dipahamkan terhadap permasalahan-permasalahan kesehatan yang ada di wilayah kerjanya. Tidak boleh dokter hanya praktek di tempat tersebut, praktek saja, tapi tidak care terhadap permasalahan kesehatan. Ya, karena nanti di perizinan pun kita juga bagaimana teman-teman ini harus mengetahui permasalahan di wilayah kerjanya. Jadi harus hidup secara keseluruhan, tidak hidup sendiri ya. Jadi harus hidup secara keseluruhan, secara utuh terhadap permasalahan kesehatan terutama di sekitarnya. Analisis beban kerja ini dihitung dengan mempertimbangkan jumlah pelayanan yang diselenggarakan oleh puskesmas, kemudian rasio terhadap jumlah penduduk dan persebarannya, kemudian luas dan karakteristik wilayah kerja. Jadi mungkin di Solo ini sangat beda dengan di Brebes ya. Mungkin penduduknya kecil, penduduknya enggak banyak, tetapi wilayah kerjanya luas dan medannya sangat sulit, kemudian daya tempuhnya ini lama, sehingga mau ke posyandu ini memerlukan waktu mungkin sampai 1 jam. Kalau di Solo itu enggak ada wilayah yang jauh ya, sehingga ini harus benar-benar diperhatikan ya. Kalau tidak diperhatikan dengan baik, nanti penghitungannya akan tidak pas, yang akhirnya standar pelayanan minimal dan indikator renstra, kemudian di daerah ada indikator kinerja utama, nggak bisa kita capai karena tenaganya sudah ngos-ngosan nih, sudah habis karena ngitungnya salah. Jadi kalau di tempat yang sudah berkembang, Contohnya di Solo ini tidak bisa kita pakai SKM, standar kebutuhan minimal. Tetapi tadi sudah saya sampaikan bisa ditambah tenaga-tenaga tersebut. Nah, tenaga-tenaga di atas
Ibu Ning,
ini
izin
ya.
Ibu Ning, waktunya 5 minutes left.
Ya, oke, tinggal sedikit nih ya.
Okay,
Kemudian tersedia fasilitas pelayanan kesehatan tingkat pertama dan pembagian waktu kerja. Kemudian di dalam melaksanakan profesinya, tenaga kesehatan harus standar profesi, standar pelayanan, standar prosedur, etika, menghormati hak pasien, mengutamakan kepentingan dan keselamatan pasien. Dan tidak lupa adalah keselamatan sendiri. Ini standar ketenagaan puskesmas, ini minimal, ya. Ini perlu penguatan, ya. Dalam mencapai target SPM dan Reinstra dan indikator lain, indikator endingnya adalah terwujudnya kesehatan primer yang komprehensif dan berkualitas, perlu advokasi kolaborasi pada seluruh stakeholder, penguatan sumber daya manusia kesehatan, baik kualitas maupun kuantitas, kolaborasi dengan BPJS, pelayanan yang bersifat komprehensif dengan mengutamakan promotif preventif, penguatan fungsi puskesmas, jejaring dan jaringan, dan peningkatan pemberdayaan masyarakat. Apa yang harus kita lakukan? Perlu penghitungan jumlah SDM sesuai dengan beban kerja, pemenuhan jumlah dan jenis tenaga sesuai dengan permasalahan yang ada di wilayah, perlu perubahan mendasar dalam pola pikir dan perilaku, kemudian promotif preventif menjadi sangat penting saat ini, tanpa meninggalkan kuratif dan rehabilitatif. Kemudian bagaimana peran tenaga kesehatan menjadi sangat penting pada siklus intervensi kehidupan kesehatan. Kemudian kolaborasi antar layanan primer dan rujukan, perlu kolaborasi antar profesi, dan perlu kolaborasi antar stakeholder. Saya kira itu yang bisa kami sampaikan, dan mudah-mudahan dengan terpenuhinya sumber daya manusia minimal sesuai standar di pelayanan primer ini, transformasi kesehatan di pelayanan primer lebih dalam arti perwujudan di pelayanan primer yang lebih berkualitas, ini bisa kita capai dengan baik. Demikian, terima kasih. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih. Thank you very much, Ibu Ning, for the great presentation. Kami mohon Ibu untuk bisa tetap stay because there is one speaker again. But if Ibu Ning have another duty, if there is a question, we will send to you. Jadi mohon untuk bisa stay sebentar, tapi kalau misalnya ada kepentingan bisa leave, dan untuk pertanyaan akan kami kirimkan kepada Ibu. Okay. Thank you. And the last speaker of the first session is Prof. Alan Lyle. So I would like to say hello to Ibu Triwayuni.
Okay.
Alan,
Thank you.
Can you hear my voice?
I can. Can you hear my voice?
Okay, thank you very much, Alan, for joining with us today. And Mr. Alan will present the paper about an international perspective on Finland challenges in healthcare RD ecosystem. And I will give 30 minutes, and please Ibu Sri to guide Prof. Alan to present in this conference.
Thank you, Ibu.
Okay.
Hi, Professor Lyles. Thank you so much for joining this workshop. We really appreciate for the short notice that we send invitation to you. Ladies and gentlemen, here we have Professor Alan Lyle from University of Baltimore. Let me introduce Professor Lyles a little bit about his background. Alan Lyle is a professor in both the College of Public Affairs School of Health and Human Services and School of Public and International Affairs. He is also a fellow of the National Academy of Public Administration. From 2003 until 2013, he served as the Henry A. Rosenberg Professor of Public, Private, and Nonprofit Partnership at the University of Baltimore. And he was recently appointed as the Henry A. Rosenberg Professor of Government, Business, and Nonprofit Partnership 2020 until 2023. Lyell's professional interest focuses on pharmaceutical economics and health policy, particularly on policies and practices to improve access to high-cost innovative medicines such as those for hepatitis and essential medicines. His research examines individual and third-party payers, government programs, and private benefit in the US market-based healthcare system, and international contrast with central government system. He has also served on editorial boards, published and lectured extensively in the United States and abroad. He was visiting chair of pharmacoeconomics 2006 and a Fulbright senior specialist twice, 2007 and 2011 at the University of Helsinki. So in a short notice, we would like to have Professor Lyell to deliver the best practices from other countries regarding health reform that are conducted in other countries. Professor Lyell, you have the floor. Thank you so much.
Thank you so much for the introduction. I think my mother would have liked that. Unfortunately, she's no longer with us. I want to verify, I believe I have about 28 minutes left. Is that correct?
Yes, you have 30 minutes, and also you might want to deliver a discussion session. Thank you, Professor.
Sure. What I would like to do is share my screen. Can I do that?
Yes, you have the access.
Okay. So now I'm sharing my screen and I'm moving some Zoom things around so that I can start with. When we talk about best practices in health transformation and major change in health systems, it's important to first understand what are the reasons for this and what is the context in which it occurs. I'll use two quite different systems. The US system, which is very much a private and market-based system. And recently, I had a project in Finland, which is a central government system, and they're undergoing major healthcare reform. It begins January 1st, 2023. Although it begins then, the legislation began 2 years ago, which is part of the observations that I would like to share, that major transformation is more like a marathon than a sprint. It takes anticipation, it takes continuing commitment and support, and a great deal of communication across the numerous stakeholders, especially in healthcare, because there's so many independent areas in which there must be alignment. And then a final overarching aspect that I would like to say before I go through a few slides to remind you of what you already know. My experience covers 15 years in management and now 27 years in academia and higher education in an applied discipline. I taught, I learned, I continue to teach systems science. So the most important aspect of understanding how to make major transformation is to begin to see what it would look like if it were a system. Most systems are incomplete, and the way in which I would say nurses, physicians, pharmacists, administrators, and policymakers understand the healthcare sector is quite different, and sometimes they have gaps. So having communication that actually shares the same reality is challenging. I'll show you, for example, a health systems model that I use when I teach, in my research, and when I consult. It's practical, it's born of experience, but it is consistent with research and published literature. A few general trends. First, I would like to observe that COVID has had a great deal of impact on our systems here. This is my wife. She is now a retired hospice worker. This gets at several trends. Pandemic and the response to pandemic, frontline workers, and workers who are withdrawing from the labor force. So having adequate personnel, training them effectively. She was certified, had advanced certification in hospice care, but she found the way in which the protocols were evolving for COVID care were overwhelming. So she is now retired. COVID is one major trend as we think about major health transformation, and it falls particularly on nursing and frontline nurses. Another is aging. These are my grandparents on my father's side. I hope you can see me. And if you look at my grandfather in that photo, he was a farmer. We are about the same age. He died about 2 years after this. So aging means something more than a number, because people who are farmers, people who do manual labor, they have more disabilities and age more quickly. So how is our system identifying and responding to the needs for that? This is my family. My father and mother, I'm on the right. I'm the small boy standing there. This is 1953. My father is the tall guy. He's a mechanic. He had no education, second grade, died illiterate. That's my mother. In that entire picture, my grandmother had 13 children. Only 3, as best I could identify, were literate, who could read and write. So if we're working with patients and with other colleagues and professionals, part of the vulnerability is the level of health literacy within general literacy. How do we educate for prevention? I noticed in your transformation document that you have preventable diseases are causing deaths and they still dominate the life cycle. This aspect of how we can address the preventable diseases concern education about how to address nutrition, hygiene, potable water, etc. If there is an investment to be made, the research and the history of a number of nations is that investment in the education of young women is critical, because the benefits are extensive as they grow up to be citizens, parents, wives, and grandmothers. They influence the decisions in their families about when to seek care, how to take care, and as well as taking care of the family. We know that for many of these diseases, you have identified, they are preventable. We have this problem where there are acute preventable and there are chronic non-communicable diseases that are also preventable if there is a lifestyle change. But what this cartoon says is that in general, there is a resistance to changing behavior. The rule is recidivism. Pills and surgery have something that will fix this or address the illnesses that result when a certain lifestyle, sedentary, perhaps overeating, too much ingestion of calories, would require that they change that. That tends not to be sustainable. So that is one of our other major trends, is obesity in the world. Another that I would suggest to you is that as you think about at your nursing conference, the types of education, skills, and resources that are available, mobilizing social capital is often a critical and hidden ingredient. This is my best friend, Dr. Bridal Pearson. He and I taught at a dojo, volunteer work in one of the poor areas in which our university is located in the city. The intent was to bring the martial arts to people who otherwise would not be able to afford it, and through the martial arts have a way of having healthy practices, of modeling behaviors, and giving an alternative to the types of street activities that some of the young people were involved in. The cost for this was exceptionally low because all of the black belts volunteered their times, hence social capital. So looking at ways in which you can triangulate, increasingly, what we taught with meditation, eventually I worked mostly with seniors because I'm older. The meditation alone is having more and more documented positive effects that can show up in better health outcomes and indices. Unfortunately, under COVID, for many parts of the world, there has been a rise in substance abuse or mental health needs. In the US, anxiety and depression have spiked during the pandemic. In fact, it has overwhelmed the counseling, psychologist, and psychiatrist capabilities of providing care. Fortunately, there are also nurse practitioners and advanced practice nurses in psychiatry who can assist with this. This is Dr. João Goulão, who is famous in Portugal as a community medicine doctor who saw the problems of drug addiction in his community, and in attempting a public health solution, was able to make so much improvements that he ultimately became the national coordinator for the program in Portugal. When we're looking at transformation, an important lesson is that leading major change, which is what this is, requires communication, and there's steps that have been identified as essential and in a specific order in order to have lasting change. Too often, it's difficult to initiate. Once initiated, it's difficult to maintain a coalition and support. And when there are some early successes along the strategic priorities, those who were resistant to change will say, okay, we're done. Look, we've done this, when it's just the beginning. So there's still resistance. I would point to you as a resource for you, Mr. John Kotter, Dr. John Kotter at the Harvard Business School. He is the professor of leadership emeritus. His book, The 8 Lessons on Leading Major Change, have spawned a generation of thinking and practice in major corporations, nonprofit institutions, and I have for you hot linked websites for that. It's Dr. John Kotter, and I would strongly recommend it. It was the gift I gave for my host during my Fulbright project in May and June. She was the Director General of the transformation. What they were doing was taking 5 municipalities and merging them into one unit. They were merging health, social welfare, and rescue services, ambulance and fire, all into one unit. Part of the reason for that was because there was an expectation there could be more efficiencies and it would be less costly as a single organization than all of these multiple smaller organizations. So it was for cost savings. Why might they need cost savings? In Finland, there is a birthright commitment that you have access to education and healthcare as a birthright. Unfortunately, the demographics of the population now are inverted. Their dependency ratio is going up. The number of people who are under a working age of 14, who are over a working age of 68, if you add those together, compared to those who are of working age, more people are becoming dependent on those fewer workers who pay the taxes. So they will not have the money to meet the commitment that's already made. That means, where can efficiencies be found? Part of that is to create more systematic behaviors rather than have islands of either geographic or other organizational units. When we say healthcare is fragmented, in the US, a market-based health system, we have difficulty with major health reform because of the differences that are strong between those who would say the government should take a role, those who would say the private sector has to have the major role. And it is so fragmented that in the Journal of the American Medical Association in 2019, it was estimated that waste, think about this number, waste occurs at the rate of about 760, let's see, billion. Yeah, I wanted to get that right. 760 billion to $935 billion. That is almost $1 trillion of waste because of the way that the system is organized. It's not a system, it's fragmented, and it needs to be one. So, given my limited time, I want to move forward to a suggestion for you. Because different stakeholders understand parts of the system or see only parts of the system, having a shared view so that there can be cooperative, constructive, collaborative work is important. It is a foundation for moving forward. This is a copyrighted figure that I have developed that allows a discussion about that, where people might disagree about what the consequences of certain initiatives are or the diagnoses, but at least we're looking at the same reality. It looks busy this way. If we had time, there is a workshop that I could give you beforehand where we build up to this and develop a systems understanding. I can share some videos that I've made with you, and it discusses this in more detail, what it means, how you would apply it as a diagnostic, as a prescriptive, as a strategic planning aid. It seems to be focusing only on physicians, but that's not the case. What it is patient-centric. If you see this focus on the patient in blue, it's to look at where does the patient go? How is this coordinated by various administrative units, influenced by policy, by the marketplace? Okay. So now I'll say a few more things and then ask if there are questions where we could have some discussion. Those things are, in research, we look for an offset effect. That is, for example, if someone has anxiety or depression and it's undiagnosed and they're seeking more medical care because they have somaticized, they have stomach ache, they have other trouble with sleeping, etc. The offset effect argues that when appropriately diagnosed and then referred and appropriately seen by a mental health professional, that the demand for somatic, for regular care drops off, even though there is a cost for the mental health care. And that is the offset effect, that it should result in fewer costs overall. I don't know that that's true, but that's what the argument is. In addition, if we are looking at waste as we attempt to do more, and in most nations, it's do more with the same or with fewer resources, identifying waste is critical. There are two types of waste, at least. One If you look in the US, there is, by the American Board of Internal Medicine, there's a website called Choosing Wisely that identifies many diagnoses and many therapeutic actions that should not be taken because they are of such low value. Hence, they're named Choosing Wisely. So choosing wisely, we would not use those services. We would instead use more appropriate and evidence-based care. Other types of waste are overuse of services, and the problem there that we work on in the US, and I'm beginning to think in Finland and worldwide, is unlearning. I graduated from pharmacy school more than 40 years ago. I did well in school. I've done continuing education. A challenge now is when there are new guidelines, if I haven't seen them, I'm still operating from older information. But when I see them, replacing that older information, unlearning and relearning, has to be built into the regular practice of our clinical disciplines. We see in the US, for nurses in particular, there has been, over the last 20 to 25 years, rapid growth in nursing research, and especially health services research that includes nursing. They can make an evidence-based contribution about how much of a difference nurses can make and in which ways. There's much more that I could say, but if I were to summarize, I would say that in general, for major transformations to occur, they need to start from a foundation of trust. They need to proceed with not only communication, but over communication, because otherwise, if it's uncertain what changes are occurring, then it's too easy for the wrong impression to be made. And last, I would say that making a system, focusing on a healthcare system like this, a system means that the focus needs to be as much, if not more, on the coordination between the parts as it is the excellence within one part. An observation in systems science and systems analysis is that if we want to improve this system overall for the purpose in which it's organized, we need to focus on those links between those interrelationships more than we focus on one or two particular parts. Making something excellent in one part doesn't translate across the system as that change starts to fade as you move around it. Having said that, I think there are about 6 minutes left, and I would be delighted to answer any questions or if someone wants to make a statement.
Thank you, Professor Lyle.
Thank you.
Professor Lyle, you said that you have a video. Are you trying to set up the video play in the screen?
No, no, no.
All right.
This is my gift to you.
Okay. Okay, thank you so much. Thank you for the presentation, and it was a good best practices, and thank you for the knowledge. It's a strategic recommendation for us in the process that Indonesia in the process of having a major health transformation 2022-2024. I think we have one question from the audience. Ibu Dewi, Miss Dewi, you may want to share your question to Professor Lyle. Please, Ibu. Ibu Dewi, are you ready with the question? Or Pak Widodo, you may want to start the question.
Okay, thank you, Bu Sri. I think Bu Dewi is on Zoom, I don't know for sure. But I think it's an interesting thing from Prof. Alan Lice. I'm just considering of the thing that would be still relevant with your topic, that currently nursing shortages is experienced over the world, including the Asian countries. How would you anticipate that? Because it's almost happened in every country, especially whenever just few or last year, the pandemic COVID is really impacted in over the world. The nursing shortages become more serious. I think it would be good to share from your opinion. Thank you very much.
To the extent that I have any insights in that, I would say that the challenge has been retaining nurses more than producing more nurses. Since that has not been as successful, because over time, as the work settings have gotten more demanding and more complex for nurses, younger nurses see a future in which they could take their education and leave and go someplace else. So nursing had developed an older workforce. And now with the pandemic, those are the people who are more likely to take this as a time in which I'm going to retire. The way in which one can go about replacing, I think probably is along a hierarchical model and related to urban-rural distinctions. In rural areas, sometimes having some access to healthcare professionals is essential, even if it's not at the highest level. So addressing the question across your system, how can you efficiently produce those who can provide basic services, perhaps screening at primary health centers. And when I was in Ethiopia, the rural drug vendors, RDVs, were just such a type of provider. There, they were allowing people who had been nurses or nursing technicians to become their own rural drug vendor. They had a limited pharmacy. They were 100, 200 kilometers away from a major city, and they would provide services to the people in their areas, in their villages. The person that I spent the most time with, he had a small consultation room in which he took blood pressures. He would do glucose testing, but it was very limited what he could do. This could be achieved very quickly because it was a limited amount of knowledge that was required. As you move through the health system, then there starts to be more than several months training, and it starts to then move up to professional nurses, which take years to produce, and it costs money. In the US, part of the change has been a movement away from hospital-based training in which there might be 3 years for a diploma graduate who, when he or she graduates, are fully trained to work on the ward. Within weeks, they could be fully productive. But the pressures on the profession have required first academic at the level of a community college, that would be an associate in arts degree for 2 years, or a bachelor's degree, and increasingly now a master's degree. That means at a minimum for someone with that training, it would be at least 6 years. So they don't quickly meet urgent needs. And I think that's part of the challenge. Also, part of the challenge is that technology alone won't solve the problem unless technology supports the system that you've designed and the human-to-human interface with that. I hope I've addressed the essence of your question, and if not, I would be glad to take another shot at it now or later.
Thank you, Professor Lyles. It explains what has been questioned by Pak Widodo, I think. I'm also ready to facilitate any more question after this session, if you don't have time. But I would like to give another one chance for Ibu Dewi, who has her raised hand. Ibu Dewi, if you are ready with the question, I would like to listen to the question. Or if I may ask you a question, for me, I also learning the process of observing this transformation instructed by the Minister of Health as well as from the President. Is there any chance that you know the research whether developing countries doing a major transformation, health transformation, has been successfully implemented? I would like to hear from you, Professor Lyles. Thank you.
So I would be reluctant to point to a specific nation because I'm not trying to duck your question, but it asks a question that's underneath that, and that is, what is a successful transformation? And a successful transformation, I would offer, is one that persists across changes in economic cycles. Currently, we have very high inflation. Currently, you're seeing high-income countries, as well as others, who are undergoing austerity measures. They're cutting back. So that's going to threaten major transformations as they are not yet taking hold. If they are early in taking hold, it may retard or slow the growth for what they can achieve. So that's economic cycles, but also, I will say, in the US, political cycles. The major political parties have completely different views. So major health transformation tends to be gridlocked politically. So we get incremental, and sometimes in ways that there's no synergy to it. So I don't know that I could point to a single major transformation because of the continuing need to support changes and what change means for many people. I can't speak to Indonesia because I haven't been, but I've been to a number of countries. As a human, as a carbon-based life form, for me, change can be threatening. So this idea of major transformation means that it takes a long time before it can be said to be successful. Some of the ways in which there can be successes along the way can concern innovative use of technology to leverage a public health center, public health nurses with people who live in the countryside. There's an example of that. In Tanzania and Uganda, there were certified drug distribution outlets to meet the need. There was one state, I believe, had one licensed pharmacist, one fully trained pharmacist for an entire population of maybe 1 million people. So trying to meet that need, there was an important, I don't know about if it's major enough, but an important transformation that when a demonstration project showed positive results in a short period of time, then the Gates Foundation funded national distribution of this initiative. In addition, let's see, I have, well, of course, I can't find it. Oh, here it is. It depends on the problem that's attempted to be solved. So if we look at, in some areas, the childhood mortality due to diarrhea is quite high, unacceptably high. There is, and I can show you, I can point you to a video on this. This Kityamoyo, this was from one of those accredited centers where it has soap, it has oral rehydration salts, etc. And the question sometimes is, how do you get the most basic products the last kilometer? And the way in which they did this was, I thought, innovative and clever. If you look at the angles on this, if you have cartons of soda, what you can do is you take this and it goes right down between the bottles, and all you see is this top. All you see is this top. Soda gets to every village. Soda gets the last mile. So with the development of this, it was something that could be sold, it could have a small profit, and there was a way to have the distribution that last kilometer in the most remote villages, because it fit right inside where the soda themselves were. So there are examples that I can point to that have made a difference. Some are like this, a distribution issue. Some are like the certified drug distribution outlets in Tanzania, which is more a training and certification, because then they were certified and they were recognized as having better information to give to patients. They weren't pharmacists, but they were more than they were before. They had some training. And there are other examples, but it's not the global system per se.
All right, Professor Lyle, thank you so much. It was a great knowledge for us. We are learning, at least we have a hope for 2024. Our transformation will be successfully implemented. And also, I know this is a very late night in the US. It's almost 11 over p.m. in the US. But since we have 400 health polytechnic students, where they are obviously important for this transformation process, I would like to invite you, maybe the last sentence, to give them a strong message, how they can contribute to our transformation, health transformation. Please, Professor Lyle, before you end up this session. Thank you.
Thank you. And before I make a concluding comment, I would like to say that this is an honor, and I particularly appreciate being able to speak with you. I come from a very poor background, as you could see from these pictures. I had tuberculosis as a child. So for me, coming out of this, education and healthcare are passions for me, because I see how they're connected. Having a career, having a job, and making a difference in the world should all come together. And that's what I see in healthcare. It has been my experience. I came to pharmacy after having started working after university in political science degree. I have always been grateful for the education and for the difference I can make in the lives of my fellow human beings because of the education I received. It can touch the patients you work with, it touches your family, it touches your friends, as you can provide information, provide services for them, in ways that others can't. They will make guesses. Over the course of your career, as you build a foundation of professional education, you will find that you will need to take continuing education and develop lifelong learning, because so much new information comes, and what we think is true now, some of it will be displaced. It will be replaced by more accurate information, which we would be delighted to learn because we want to make a better difference. So this idea of lifelong learning, we hear the term, but once you see a person that you couldn't help, and then you learn of something new that would have helped them, it has more meaning than just learning facts in a science course. It is deeply a human process, and I commend you for making this commitment. It is, I think, a sacred honor that we have when we work in healthcare. Thank you.
Thank you, Professor Lyle. It's a very strong message for our students of Health Polytechnic. I know it's end of your session, but I see one question in the chat. You might want to respond it through chat. It will be appreciated. And by the way, we really honored to have you in this session. Looking forward to another your session in the important workshop of the Health Polytechnic. Thank you so much, Professor Lyle.
Thank you. Have a good day.
Bye-bye. Have a good day.
Bye-bye.
You too.
Okay, thank you very much, Ibu Dr. Wahid, MSc, and also Prof. Lyle, but there is a question from
Okay.
okay, the chat room chat. I will read the question. Good morning, my name is Mariam Putri Hanifah from Health Polytechnic Surakarta. I want to ask a question. As we know that today's life feel so fast, and the demand of a life that leads us to unhealthy lifestyles. The impact of health and mental problem are currently of particular concern. Suicide cases in the younger generation, especially in my country, are quite alarming. So what is your response to this problem, and what is the most effective solution to keep the current generation health and mental health healthy?
I think this is perhaps one of the most important questions we can ask. I think as a parent, as a leader, as a community member, as a citizen, our most sacred job is the safe development and the full human development of the children that we have in our care. I'm looking for an award I received because I wanted to show this as an example, but I can't find it now. The award was from this past April. It was for being mental health ally. I received it from the students and faculty at my university. So there are going to be many pieces to this, Miriam, and I'm only going to be able to touch on a few. But the first is to have services that are available, but importantly, to have people in connection who can tell when somebody else is starting to have more difficulties, more sadness, more of other things that would, you point to suicide, but it can be something short of that. It can be a profound sadness. Parasuicide, the attempts are multiples of successful suicides. So we can look for information about those. We can highlight those who make a difference, who speak out, who are advocates. And awards are one way. It isn't about me. What it did, it highlighted the activities of being an ally for those who have mental health needs. to remove the stigma that it's a weakness rather than it's part of the human condition. As a pharmacist, I know the number of people from all walks of life who came into my store and received antidepressants, anxiolytics. It's a part of the human condition. So accepting that can be profoundly impactful. For suicide prevention, hotlines where people can call can be helpful, and especially in situations where the action might be intercepted. In San Diego, in California, there's an island. It's not Catalina, Coronado. So the bridge that goes over from San Diego to Coronado is very high because ships pass under it. At the top of that bridge, just at the railing, there is a telephone and there is a sign, and it is a suicide intervention hotline. And it was, please pick up the phone before you jump. So there are some things that are more environmental. The alarming rate for children, I can only speak to the US with close knowledge on this one, is that so much pressure sometimes is placed on them to excel, to be in so many activities. That's one part. So addressing realistic expectations and what does it mean to be human? In addition, the expectation of being constantly busy, I think that we can benefit if we teach meditation. We teach looking for depth of connection and learning. We try to facilitate community for younger people. Many times, not always, but many times, suicide and feelings of desperation and descent into behaviors that can lead to criminal justice system occur because people have become isolated, they've become hopeless. And creating a way of addressing that sometimes requires organized religion, working in concert with community and community agencies, working with government. Miriam, I hope I'm addressing your question okay.
Yes, thank you, Professor Lai. Sorry to keep you on the last minute, but I think your explanation are totally very informative for us. So Ibu Mariam is happy to listen to your recommendation and explanation. So I give it back the next session to the host. Thank you so much, Professor Lai. Thank you, Ibu. So after this, maybe we would like to have our Deputy Minister having the opening of this workshop. Thank you, Professor Lai.
Thank you. Have a wonderful day.
You too.
Bye-bye.
Bye.
Thank you, Prof. Alan. Thank you, Ibu Dr. Sri Wahyu, MSc, for joining us today. Ladies and gentlemen, because of the limitation of time, so I think the first session of the conference is finished. For all attendants who want to ask a question both to Mr. Dr. and Ibu Ning, you can write in the room chat, and then there will answer for your question in the chat room also. So I will give time to MC. Thanks so much for your attention. I think that's all for the first session of the seminar today. And I close. Before I close, I would like to say thank you to Ibu Sri Wahyuningsih, who already to be a speaker, and Mr. Widodo for your kind and yeah, that's all. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Waalaikumsalam.
Thank you, Mrs. Siti Lestari, for guiding the first plenary session.
Ladies and gentlemen, now we are going to the second plenary session. The second plenary session will be guided by Mr. Widodo, Master of Nursing, as moderator. To Mr. Widodo, the time is yours.
Yeah, thank you very much. Ladies and gentlemen, we would go to the next session. For the next session, it would be talk from Ibu Ariandi Anaya. Halo, Assalamualaikum Bu Dirjen.
Waalaikumsalam.
Yeah, baik Ibu Dirjen. Let me introduce. My name is Widodo. Bu Director General of Health Worker will deliver actually for the keynote speaker because of she's very busy, so now she just be able to join for the moment. So Bu Dirjen, about 10 to 30 minutes would be the Zoom meeting is now yours. Thank you very much.
Yeah, thank you, Pak. Good morning, everybody. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Greeting to all of us. Shalom, Namo Buddhaya. It is my pleasure to address you, Director of Health Polytechnic of Surakarta, distinguished speakers, faculty members of Health Polytechnic of Surakarta, participants to this conference. Praise and thankful, let us pray to the presence of the Allah Subhanahu wa Ta'ala for all of His grace that have been given to us all, so that today we can attend the 6th International Nursing Conference held by Health Polytechnic Surakarta. I want to give my gratitude and appreciation to Director of Health Polytechnic Surakarta for organizing this conference. Dear distinguished guests, ladies and gentlemen, Indonesia has made notable progress in improving the country's health and nutritional status. Maternal and infant mortality, childhood stunting, and communicable disease have declined. Such improvements were achieved through a range of efforts to improve equal access to health services throughout the country by improving the national health system and securing financial protection to improve access and reduce catastrophic health expenditure. Despite the improvement, Indonesia's demographic and epidemiology transition has resulted in a switch in the burden of the disease, namely from the communicable disease, and unhealthy lifestyle driving these things include imbalanced diet, physical inactivity, and smoking. That is an additional significant effort to reduce the prevalence of the communicable disease such as HIV, TB, and malaria are still required. This situation of the emerging non-communicating disease in the face of the persistent communicable cause is known as the double burden of the disease. Now, Indonesia also experienced a double burden of the malnutrition reflected in prevalence of the obesity alongside high rate of the undernutrition. Indonesia is currently entering an initial process of the population aging with the increasing life expectancy and an increasing a number of elderly, and the elderly has a higher level of the health vulnerability of as well as deteriorally physical ability and well-being. A major concern is the growing burden of the degenerative disease. The degenerative disease exposes those affected of the diverse level of the dependency ranging from the mild to total. The elderly who experience stroke will face a total dependency compared to those having heart disease, diabetes, rheumatic condition, or injury. If we are looking for the result of the Risk-Nakas survey on 2017, showed that a substantial gap remain in the availability of the health human resources in Indonesia. Lack of the physician, especially public health personnel, occur at the many puskesmas, particularly those is in the eastern region of the country. Lack of the health human resources, especially specialists, also occur at the advanced healthcare facility, such as hospital. The rapid growth of the private healthcare facility in the big city, inadequate incentive for service in underserved and remote area have resulted in a major health human resources disparity, with the eastern region of the country most adversely affected. Dear ladies and gentlemen, starting in 2022 until 2024, the Ministry of Health implement transformation in health sector. The purpose of the transformation is to accelerate the solution of the health problem that occur with an approach that with no meaningful progress before. We built 6 pillars of the transformation, including transformation of the primary services, referral services, health resiliency system, health financing, health human resources, and also health technology. The transformation in health human resources include 3 priority activity aiming to achieve the indicator of the RPJMN 2022 dan 2024. The 3 priority activity include the fulfillment and the acquisition of the health human resources, increasing the competency and also training of the health human resources, and development of the functional position of the health, and also the career of the health human resources. We are still trying with all our power to overcome the COVID-19 pandemic, but the various attempts to overcome health problems in our country still need to be done. This effort includes maternal health and children, family planning, and reproductive, and then accelerating improvement of the community nutrition, improvement of the disease control, and also the promotion, and strengthening the disease, strengthening of the disease control. Such effort is not possible to be performed only with the curative and rehabilitative conventional approach. I think preventive and promotive approach should be the main thing that we should do overcome to the health problem. Collaboration between profession, especially health profession, is the key to successful overcoming our health problem at this time. No single health profession can solve all the health problem with all its very complicated. Interprofessional collaboration, it is a must. Strong cooperation, completion, respect for each competence, then any health problem will be resolved. Indonesia is a rapidly transforming a diverse society that presents a unique challenge for the health system. More recently, a rapid increasing in obesity and non-communicable disease has been observed, making Indonesia facing emerging and catastrophic disease. Therefore, a new health system approach starts by universal health coverage aim to create a more adaptive, effective, and equitable system in a complex environment. There are three that need attention in Indonesia. First, lowering inadequate between province by providing adequate health infrastructure and facility, including better distribution of health workers, especially in a poor province that have low service coverage index. Then the strengthen health promotion and preventive effort through cross-sectoral coordination. National and local government can work together with the communicative and religious leaders in developing communication strategies to deliver health information to the public. Successful deployment of transformation in the health sector will require strengthening community level frontline and clinical digital health information system and data driven optimization for high impact and sustainability. An integrated dynamic health system that is adaptable to rapidly developing society can provide an affordable and sustainable path toward health for all and the achievement of the underlying principle of our target. Distinguished guests, ladies and gentlemen, currently the current health crisis that we are experiencing and the economic and social crisis that are already on their way put ourselves in a new, unexpected and complex context. Issue and challenge such as globalization and technological development will become more apparent, and also the world will not be the same after this crisis, and higher education institution and higher education system will not be the same after this crisis. In a post-crisis situation, new expectation will be put on a higher education institution in terms of the link of the communication, in terms of teaching, and in terms of the international strategic and mobility. In this globally and digitally interconnected world, all the kind of the healthcare worker must deal with the challenge. Universal topic like a 21st century skill, leadership, intercultural competence are connected. In this changing world, we are facing more and more complex problems. The challenges in our work are having a direct impact on the medical industry. The 21st century has the most advanced medical technology compared to any previous country. But it also has a unique problem that makes it necessary for the healthcare to adapt. From nursing shortage to the change in the healthcare technology, the healthcare industry are working hard to be prepared for the changing needs in the medical community. Qualified and training nursing leadership is crucial to ensuring the healthcare facility are able to keep up with the changing needs for the industry. As more individuals become qualified to lead in the healthcare field, more mind will be at work to help challenge and tackle challenge and problem. In response to this urgent and growing need to healthcare worker for who qualified to lead in the healthcare field, health students should be provided with a range of skills that relied not only on the cognition, but also on the interdependency of the cognitive, social, and emotional character. Health student mastering in specific hard skills and mastery of particular skill set with a focus on digital literacy are increasing in high demand. ladies and gentlemen, before I end this speech, I would like to thank to those who has participated in this conference. I'm sure today we are gathered here with the same mission to overcome the learning crisis we are already living and respond to the pandemic we are all facing. We must that the most important that people must stay productive and be safe from the virus. Living in a peace with it does not mean that we are giving up, but we will be adapting. Those my speech. I hope this day become the best moment for us to do better in the future. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you to Dirjen. Hello. Yeah. Thank you very much for your speech. This is very important for some message for us to be together, to face the pandemic together, to stay and to improve our knowledge innovation to face the very complex problem in the health. And I think it's time for Bu Dirjen to have another very important things to do. So thank you very much. Terima kasih Bu Dirjen sudah berkenan hadir dan mohon maaf ada kekurangannya.
Terima kasih Mas. Terima kasih.
Thank you Bu Dirjen. Terima kasih Bu Dirjen.
Sukses ya.
Terima kasih Bu.
Thank you.
Okay, ladies and gentlemen, we just hear the speech from the director of technical problem. We just hear the speech from the Director General of the Health Worker of the Ministry of Health of Republic of Indonesia. Now we move to the next speaker for this session. I would introduce Dr. Hans Garcia. Can you hear me, Dr.?
Yes, I can hear you.
Okay, thank you very much. Good to see you. Thirdly, I would read your CV. It's really very CV actually. So I would just read some of the CV that you have. Lawrence Garcia, Desatesis Porto San Pedro, Bin Unido Bohol. He is an associate professor 5 and current designation is officer in charge, office of the board and university secretary. In affiliation is Cebu Normal University of the Philippines. He has very long educational background, and the last would be postgraduate studies, Doctor of Science in Nursing, Major in Gerontology Nursing, Cebu Normal University College of Nursing by 2016, so still very young. Yeah, and then works experience also very long pages, and then awards on in recognition also. He get so many presidential citation, especially in 2019, also 18, and then member of many association here from the Cebu Normal University Faculty Association, Sigma Theta Tau International Honor Society of Nursing, and still many other member. And then he also gets so many grants and projects, at least about 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, possibly so many. And recent completed research about the phenomenon of waiting to know life experience of person exposed and tested for SARS-CoV-2, and then the entire continuum of suspected COVID-19 patient completed. College of depression and the effect of ear seat acupressure using the 5th point data protocol on depression level of the in Metro Dumaguete Combat. and hope practice in sequential narrative completed, and still so many publication. Interesting here, innovation and invention is about novel partners care with hair retainer. Maybe you can share a little bit about this, and so many planning activity. I think it would take so long time to read all of your CV because of time constricted. So I would give the Zoom time for Dr. Lawrence Garcia to deliver your topic is catastrophic disease and the impact of the pandemic, about 25 minutes. Zoom is yours. Thank you.
Thank you so much for the very generous introduction. Maayong buntag, magandang umaga, salamat pagi. Good morning, everyone. Thank you so much for having me here and making me part of the 6th International Nursing Conference. So I'll be sharing to you the impact of the pandemic on the older persons. So before I proceed, I would like to give you a disclaimer that I am not an expert in gerontology nursing nor an expert of COVID-19, but I am an advocate of the care of the older persons. That's why a lot of my works are centered on the care of the older persons, and a lot of my advocacies is related to this population. So allow me to walk you through the impact of the COVID-19 on the older persons, which are among the most vulnerable population during the pandemic. Older people are at higher risk of serious illness, and their odds of survival are at the lowest. We did not understand deeper the COVID-19 pathology or pathophysiology because we already know that at the time of the height of the pandemic, a lot of people are experiencing severe symptoms of the pandemic, and most of them are in the older population. The severity and outcome of the coronavirus disease largely depends on the patient's age. So that's why a lot of countries have implemented restrictions on the mobility of the older persons during the height of the pandemic. Adults over 65 years of age represent 80% of hospitalizations and have a 23-fold greater risk of death than those under 65. That's why a lot of focus has been given to them during the time of the restrictions. So why the disease is particularly dangerous in older people is not yet known. So we really don't know why older people are the most affected by the pandemic, and is poorly understood at the molecular level. However, it is clear that age alone is by far the most significant risk factor for death due to COVID-19, knowing that age comes with degeneration in a lot of aspects of the body, thus exposing them to greater and severe symptoms brought about by the disease. The COVID-19 presents a range of particular risk for the older people or the older persons. We can look at economic well-being. The pandemic may significantly lower older persons' income and living standards. Already less than 20% of the older persons of retirement age receiving pension. So on top of the physical illness, the economic well-being of the older persons are being affected. Mental health can also be affected. Physical distancing can take a heavy toll on our mental health, and not only for the older persons, but even to the younger people, especially those needing socialization. Living alone and being more digitally included than others, the risks are higher for older persons because of the digital divide, which we will explain later. Some of them are also responders. Older persons are not just victims. They are not just those restricted to go out. They are also responding. A lot of them have been contributing to activities even at home. They are also health workers, carers, and among many essential service providers. Not only that, the restrictions stop them from performing their roles in public. Life and death can be a risk also for older people. Fatality rates are 5 times higher than global average. An estimated 66% of people aged 70 and over have at least one underlying health condition. So though it may be not normal for older people to have diseases, but a lot of older people have comorbidities that comes with their age. And vulnerability, essential care that older persons often rely on is under pressure. almost half of COVID-19 deaths in Europe occurred in long-term care settings. So in countries where there are long-term care settings, there are reports that almost all of the people inside the long-term care facility have died because of COVID. Older women often provide care for older relatives, increasing the risk for infection because those being cared at home or in long-term care facilities exposes also the carers to the infection. And then abuse and neglect. In 2017, 1 in 6 of older persons were subjected to abuse. With lockdowns, reduced care violence against older persons is on the rise, and we will be discussing that in details in a while. So the virus impact on older adults goes beyond a higher risk for serious infection. So if we look at the effect of the COVID-19 to the older population, it goes beyond just the severe symptoms brought about by the disease, but it also includes limited access to care for all health conditions and considerable social and economic hardships. So we look at not only the disease, but how it impacts the whole of the person or the whole of the older person. Let's look at access to healthcare. I know a lot of our speakers were talking about healthcare systems and access to healthcare of the general population, but let's focus on access to healthcare of the older population. In the face of life-threatening pandemics like COVID-19, older persons face challenges in accessing medical treatments and healthcare. In the normal times, a lot of older people have been having difficulty accessing healthcare, not only because of the cost of medical treatment, but because of the difficulty of moving and transporting them to the place of treatment. In developing countries, weak health systems or healthcare requiring out-of-pocket expenditure leave millions of people, especially those in the poorest groups, without access to basic care. Because even at this time, a lot of countries don't have free access to medical care. So that's why the poor will not have access to treatment. Older persons with disabilities and chronic conditions may experience further difficulties in accessing healthcare and become more marginalized, not only because they cannot afford the care, but because they are not allowed to go out to access healthcare. So that's why there are a lot of cancellations and there are a lot of disruptions in the care schedule of our older people during the time of the lockdowns brought about by the pandemic. In terms of access to care and support, they are more likely to have ongoing needs that requires medication. It comes with age, that there are certain concerns that must be addressed, and some are experiencing comorbidities needing assistance and require routine home-based visits and community care. But due to the lockdowns, the older people may not be visited by care providers or medical professionals because of the fear that they might get the disease. So even before the pandemic, it is already known that such arrangements were patchy. A lot of older people don't go to the hospitals or don't seek treatment, especially in hinterlands and places that are geographically isolated. These arrangements, however, are now at risk of being further disrupted by measures to limit the spread of COVID-19. Since our older people are not allowed to go out, many older persons no longer have access to essential care and support. So they are left to care for themselves, and others who cannot care for themselves are left alone at home, sick and experiencing their existing problems. So this is a particular problem for older women because they are overrepresented among older persons and are more likely to require long-term care. In an article on factors influencing access and utilization of health services among older people during COVID-19 pandemic, we look at access to COVID-related services. This require specialized service due to a higher probability of morbidity among population group. Since the disease is more pronounced in older people, specialized service must be provided to them. A higher occurrence of acute respiratory distress syndrome and a high risk of presenting complications from COVID-19, and the particular need for ICU service because of their age and because of the existing comorbidities, making it difficult for them to be cared at home. While there are COVID-related services, these older people also need access to non-COVID related services, just like home care, telehealth services, routine or outpatient healthcare services, oral services, mental and palliative services, and even medications and chronic and other healthcare services. So these are among the things that should be provided to them and should have access. In terms of violence, neglect, and abuse, even before the start of the pandemic, abuse of older persons have been on the rise. With the rise in number of older people in our population, it comes with the number of abused older persons also. So since the outbreak of COVID-19, there have been widespread reports of increased rates of violence against women, knowing that women are greater in number in the older population, and particularly intimate partner violence exacerbated by the lockdown conditions. Though in some countries they may not be reported, but there are a lot of reports that these older women have been abused at home because of their dependence on their family members or dependence on their spouse. While age disaggregated data is not available, policy responses need to incorporate the needs and rights of the older persons, especially women whose dependence on their family members for survival makes them more vulnerable to abuse. So if we look at impact of physical distancing, I know a lot of us experience problems with being not allowed to be socializing with people, to being asked to stay at home, and being not able to hug or touch the hands of our family members. COVID-19 risks aggravating the social exclusion of older persons. It makes it more difficult for older persons to socialize, wherein socialization is a very important tool for the older person to attain life satisfaction. While such measures are crucial for ensuring the safety of all, they need as much possible factor in the realities faced by older persons so as not to increase their social isolation and worsen their health outcomes. They have no choice but to follow the implementation of physical distancing. Thus, many older persons rely on home and community services and support, particularly those living alone, which do not allow for in-person social interactions and other mitigating measures. So if you would look at how isolation and loneliness affect the body, 32% increased risk of stroke, 29% risk of coronary artery disease, 25% increased risk of cancer mortality, 50% increased risk of developing dementia, 59% increased risk of functional decline, and 45% increased risk of death. So it really affects the body of the older person, not only their mental well-being. While they are asked to stay at home, our older people also experience ageism, discrimination, and stigma, knowing that when they go out, people would always think that they carry with them the disease. At a time when more solidarity is needed and COVID-19 is escalating entrenched ageism, including age discrimination and stigmatization of older people. So people don't come in contact with the older person when they arrive at home because they're afraid that the older people might get the disease from them. So it's a two-way process. Older persons being avoided and people avoid older persons so to protect them. The protection that they provide for the older person means it comes as a form of discrimination and stigma because older person really need socialization and interaction, but due to the disease and the nature of the disease, they become discriminated. So it's worrying that remarks and hate speech targeting older persons have emerged in public discourse and on social media because they think older persons are the ones spreading the disease. And this is a form of expressions of intergenerational resentment. On the impact on mental health and well-being, 90% had worse depression or sadness now among older adults 50 to 80 because of the lack of socialization. Not all older people are living with their family members. A lot of our older people are living alone, especially those in highly urbanized cities and industrialized places. As older persons increasingly live alone in many countries, the loss of and breakdown in social networks associated with COVID-19 may create a situation in which the significant mental health and psychosocial support needs of many older persons are no longer met, because not all people can come in contact with their social network. For the many millions of older adults who live in care facilities, physical distancing measures that restrict visitors and group activities can negatively affect the physical and mental well-being of our older persons, as mentioned earlier. So it doesn't only cause depression, it also causes the severity of other existing diseases. On the impact of digital divide, though a lot of our older people are already using technology, many still are not able to access the digital technologies. The internet and other digital technologies, though have become a window to the world during the lockdown, it's good for the younger generations and it enables them to connect with family, friends, and communities. Many older adults have limited access to digital technologies due to lack of knowledge, due to the lack of capacity or the lack of device, and also the lack of necessary skills to fully exploit them. While about one half of the world's population has internet access, it's also a reality that older persons remain disproportionately on offline. A lot of our older persons have no access to internet, especially in areas where internet connection is limited, thus preventing them from socializing in the use of technology. In a study we conducted during the height of the pandemic on living alone and using social media technologies, the experience of the Filipino older adults during the COVID-19 pandemic, it can be seen that social media technologies afforded older people who are living alone the opportunity to enhance their confidence in the use of technology in general. A lot of our older people are forced to learn social media technology, knowing that they have the time to explore it. At the same time, they have to do it for socialization. The experience of living alone and coming in contact with the world through these technologies during the time of the pandemic allowed them to acknowledge the convenience of its use and maintain their productivity while staying at home rather than feeling lonely and helpless. So use of technology provided a positive impact on the older person. It basically facilitated the need to maintain social connectedness and inclusivity despite distance and time boundaries. So as mentioned in the previous slide, 56% are able to do video chat, along with the experience of struggles, because we all know that these are not digital migrants. Unlike younger generations who are digital natives, they have the pleasure of using technology. They found meaning, joy, hope, and a sense of being at the helm of their own life's situation. So for those who are able to access technology and the internet, they have been having a positive outcome during the time of the pandemic. Now, looking at this, the economic and the social aspect on employment and social protection, many older persons around the world live in poverty and experience social exclusion. We all know that a lot of our older persons have not been prepared to retire. A lot of older persons are still supporting their younger generations, supporting their family members. So a lot of them are still in the workforce, trying to survive the daily expenses. However, the lockdown prevented them from doing their usual employment. So the risk of poverty increases with age, with a higher percentage of older persons living in poverty, as high as 80% in some developing countries. So we don't expect older persons to become rich when they retire, but some would have to rely on multiple income sources such as paid work, savings, financial support from families, and pensions, which has been jeopardized by the COVID-19 existence. Therefore, the pandemic may significantly lower older persons' income and living standards. So some might have difficulty accessing their money because they cannot access technology to get money, and they cannot go out to withdraw cash from the bank because of the restrictions. So some may have money, but they still have difficulty accessing their own money. So this will likely to have disproportionate impact on older women who are living longer because of their age. In an article that we also created or we wrote during the time of the pandemic on socioeconomic and political dimensions of COVID-19 dispersion, as the government chooses policies to follow in response to the pandemic, it is imperative to understand precisely how both the pandemic and potential government interventions will impact everyone. The intervention should also be catering not only to those who are still productive, but it should also focus on the older population who might be directly affected. Maintaining public and political will for extending social distancing measures and keeping people housed depend on easing financial pressure on people who have been forced to stop working or have otherwise lost income from jobs or businesses. And this is very true to our older persons. In addressing both the public health crisis and the economic crisis, timely data can help policymakers assess and improve relief efforts so that everyone can afford basic needs until the crisis lifts. So older people have to be counted, have to be reported. Their concerns have to reach our health and government leaders. On universal health coverage, which has always been the aim of all countries, over the next 3 decades, the global number of older persons is projected to more than double, reaching over 1.5 billion persons. A lot of us will be joining the older population, and hopefully we join the older population as healthy as we are. Universal health coverage cannot be achieved without addressing the needs of the older persons, because when we say universal, it should be health for all. Thus, we don't leave behind older people, though they are nearing the end of life. Strengthening public health systems is a part of building global health security, and universal health coverage is critical to ensure better health and well-being for all people everywhere. So that should be the spirit of the universal health coverage, which may also include the care and support services. When we look at this aspect, the pandemic has exposed inadequate and underfunded care and support services for older persons. It became obvious during the pandemic that there are a lot of programs that are not in existence and older persons are left behind. So many older persons have no access or no choice and control over care and support services. So this type of care and support services vary, but in many places, services are limited. So for most family members are the only care and support providers available to them. Thus, they have to stay at home and receive care from untrained caregivers. While on legal
Sorry,
protection,
the time is 5 minutes left.
yes.
Thank you.
While on legal protection, many countries lack adequate legislation at the national level. We all know that we were caught off guard by the presence of the pandemic. Thus, a lot of our programs for the older persons were not implemented and were not in place prior to its presence. So together with the absence of dedicated internationally agreed framework, there will be gaps in the care and protection of the older people. So these gaps must be ensured to be filled so that the rights of the growing population of older people in all societies will be ensured. So looking at the key messages from all of the following impacts on the older person, the pandemic has brought unprecedented challenges to humanity, specifically older persons, and this presents disproportionate threat to the health, lives, rights, and well-being of our older persons. Older persons have long been subject to inadequate protection of their human rights and overlooked in national policies and programs. It's about time that waking up with COVID-19 in our efforts to recover, this should be an opportunity to set the stage for a more inclusive, equitable, and age-friendly society anchored in human rights. So let's make the COVID-19 recovery an opportunity to provide better programs and services to our older people. So these are my references. These are research articles, government reports, issuances, and international policy briefs to guide us in the care of the older people. To end, old people die not because no one cared for them, but because someone they expected care from did not bother. So we as nurses, we as healthcare providers should do our part in caring for the older person. They should not die because we did not care for them, but instead we should provide our best so that they will live a better life as they move towards the end of their lives. Terima kasih from Cebu Normal University. Again, I am very much grateful to the organizers for making me part of the 6th International Nursing Conference. Daghang salamat. Thank you very much and good morning.
Thank you, Dr. Lawrence Salamat. And would you please, for a while, we still have another 2 speakers. We may have another question session at the end. Okay, then next we go to the next speaker, Ms. Chutarat Tongsalap. Can you hear me, Ms. Chutarat?
Yes, I can hear you.
Okay, thank you. Good to see
Okay,
you.
good morning.
Good morning. Sawadika.
สวัสดีค่ะ
Ms. Chutarat Tongsalap, briefly read your CV. The now is doing her PhD student of the Doctor of Philosophy program in nursing as an international program. And her relevant work experience started from 2002 as a registered nurse in Songkha Hospital. Then by 2014 as head nurse of family practice and primary care department, then head of strategy and planning department and acting head of administration department in 2016. She moved to Purumarajunani College of Nursing. Please correct me if I'm mistaken. Then she became head of lecture in charge of mental health and psychiatric nursing course and some other job here. And additional work experience also many here as a lecturer of Surin Provincial Mental Health in drug consulting knowledge, and still some other here. I would not read for all. Then also interesting, she also become a volunteer by 2011 as voluntary for first aid mental health basic to the victim of Thai-Cambodian border war. Okay. In year 2014, voluntary for first aid to flood victim of Syrian province. And 2021, voluntary for vaccine clinic of Chulalongkorn University. I suppose it would be a vaccine for COVID-19, isn't it? Okay.
It's okay.
Yes, in scholarship,
Don't be worried about it.
yes, very interesting thing. Almost every country explained about this. And scholarship, the current now, see, start from July 2018, scholarship of Prapurom Ratchanok Institute of Health Workforce Development, Ministry of Public Health, Thailand, for studying at Faculty of Nursing, Chulalongkorn University on Doctor of Philosophy program in nursing. Okay, that's interesting thing. And qualification and award year 2011, 11, outstanding nurse of volunteering in social service at the provincial level student. She has many research and the language is English and Thai, of course. Now, Ms. Chutarat, we would invite you to deliver your topic about panic management in facing emerging disease, isn't it? So
Yes,
the Zoom
thank you.
is now become yours.
Yes, thank you very much for moderator is introducing me a lot of things. So sorry, I didn't cut some part in my CV, make you hard to spell in is like a Thai language. So sorry about that. And today, first of all, I have to say it's like I'm delighted to be as one of the speaker in the 6th International Nursing Conference. And thank you very much, all of you here. And for today, the moderator talked about my topic already. The topic as a panic management in facing emerging disease, right? But I thought when all of you think about it, the panic management, I think you will thought about the panic disorder or panic symptom. But today, I didn't want to talk about the panic symptom or panic disorder. We will talk about the panic feeling and how to deal or how to manage it in the by using nursing role. That for my topic today. And before we talk about the panic management, we have to know. I'm not so sure. It's like in the before session is talk about emerging disease already or not, but I will talk about emerging disease a bit in the way of psychiatric nurse make understand the emerging disease in easy way. The emerging disease, or when we searching in the paper, some paper use the word emerging infectious disease, or some paper use in the abbreviation in EID. This is an easy way to talk about emerging disease, and when we talk about it, we just think in easy way. It's like the new disease. And when we got the new disease, the new problem come to the health system, and after that, we have to know how to treat it. That means we have to find a new treatment. That's the way to think about the emerging disease. And when you read it and found, it's like a can read and meet the emerging disease, you will see another word. It's called re-emerging disease. It's like many times it's come together when writing in the paper. Re-emerging disease is a way to think in easy way, like the emerging disease as like the old disease, but that disease make the new problems and really want the new treatment. This is the way to think about the emerging disease in the psychiatric style, because we didn't have like an expert. It's like how to deeply in each disease of emerging when they come. When we talk about everything new treatment, new problem, that means the people who deal with it have to stay in the feeling of uncertainty. When we feel uncertainty, we feel fear, anxiety.
Hello?
Yeah.
Your slide
Hello?
is not up yet. Your slide?
Oh, yes, not yet. Yeah.
Yeah.
Not
Okay.
yet, yeah. And this like the way to think about emerging disease, which I want to talk with you why we have to think about how to manage the panic management. And for the emerging disease, I have to talk about history a bit, because I can say this emerging disease is we are familiar with it because the EID, they have been with us for a long time. You see in the first picture, we have the plague. This is starting since 165 AD, and there is re-emerging 2 times. And then we meet with the back days. Maybe I'm not so sure the student is know about this disease or not. But we quite familiar with EID, but that different name of disease come. It seems like I think all students know about the Ebola, right? The flu and Spanish flu. I think nurses know about it because this is a history to learn about the disease. And another one is like when we talk, I think this our student as a new generation, maybe it's a generation Z. Maybe they will familiar with this timeline for imaging or re-emerging viral disease in the 21st century. You see, starting this day, we have the re-emerging of dengue, and when 2002 or 2003, we missed SARS, right? And until now, we have a lot of kind of the emerging and re-emerging disease. That's why I say we are familiar. But every time when it happens, we still feel fear, we still feel anxiety because it's different impact when occur it. Such as it, I think the last session talk about is like a impact with the economic and impact with the health insurance and many else. A lot of, and this the last one we still stay on process of this emerging disease, and this is a COVID-19, right? We familiar with it, but still got the problem why we are feel like a panic or something like that. And after we know this timeline, we will know like oh, why is feel panic, because this is like I searching for appropriate with we are Asia, right? And this is the important factor leading to got the emergence of the infectious disease. It's like there is a driving force in Southeast Asia, the population growth, and it's like during is between the urban and rural grow up, something like that, and population movement. Yes, sure, when we are movement, we have to, there is like animal trade, or we have like the livestock production, and is related to the water and sanitation and the economic and industry development and climate change. And also why is like related with the drug resistance, because of like we have the new microbacteria, we have the new viral adaptation to fighting with the human. And when human uses something wrong, yes, surely drug resistance will happen. That's the a lot of factor and can get the emerging disease in the world, right? And for why after factor come and the emerging disease is happen, why we have to panic. I have to say a bit about the level of disease classification related to the psychological impact, because of like we have forwards like endemic, outbreak, and epidemic and pandemic, but we have separate divided into 3 levels. For the first level is like the level of endemic and outbreak. This level is like when the EID disease will happen is like in the specific area, a small area, and that disease make like can control, and it's not over expectation. It's like oh, that area can predict, oh, it's 1 month will stop, 2 months will stop. This is called endemic and outbreak. It seems like when COVID-19 starting, and in the Chinese, right, it's just like a return area in some village. That we will call the endemic. That means the population is not too much to deal with that problem. But after that, after cannot control, it will become big. We will call the epidemic. When we come to epidemic level, that means the outbreak over greater area, and starting for hard to control that disease. And that means the health system starting for have to think a lot, or how to deal with it. And every information come to the people how to deal. And this is safety or not when we have to go outside, or how to transmission in this disease working, how to that make the starting for the psychological problem. And for this time, we can know about the COVID-19 pandemic. That is mean like the disease is widespread around the world and harder to control. And when everything cannot control, the people will miss feeling of panic, fear, because of every people have to deal with the uncertainty feeling about the period of each disease, right? And for the symptom in each disease is different. It's like a COVID-19. COVID-19 is different variants. In the first variant, or very severe, is impact to the lung, as hard to give the treatment and still there no the vaccine. Everything is very hard to deal, and we will got the case, high death rate case, right? And the new case, huge new case. And when we got the huge new case, that means the health system is will got the problem, which I think we ever watch and learn in the social media a lot, like, oh, the hospital there are no the bed enough for the patient, and shortage of the medical protective supply, the medical and nurse staff is not enough for each country, each area. This is make every people, include the health provider, feel panic. And another thing that, and this is very important, why is panic? Because every pandemic, we will got the unique infodemic. Unique infodemic is like the overabundance about the misinformation. A lot of information come to every people in easier way in the social media, but we don't know which one is correct, which one is not correct. That the problem. When we know, some people know, oh, this herb can help to deal with COVID, don't need to go to the hospital, and we try to fight it, we try to stop it, but there are no the evidence to support it. And maybe some people is like the symptom is bad after try to do in their belief way, something like that. That's why it's like a pandemic. It's pandemic from the emerging disease lead to the panic feeling in the people and health provider. And for the reaction, psychological reaction to the EID in the general public, we can say in the easy way, it's like the first thing when there is like an emotional distress, right? Such as fear, anxiety, panic. This when we feel something, we will, in the psychiatric way, we will think when we feel something, it will impact how we will show the behavioral, such as when we feel fear about how the disease transmission, and there is the rule, oh, you have to use mask, even though the WHO say, oh, you can use mask just only 2 layer is can, okay, it's safety. But when we feel fear, some people use 5 layer, some people use medical mask with the fabric mask for protect. That is like a called maladaptive behavior. And then there is some people try to do like a defensive response, such as it's like when there is announcement, oh, the people please inject the vaccine, because there is many kind of vaccine can help to protect the virus. But they don't believe and try to defend and respond like, why have to do? Some country there is like a protest, and some people like, oh, just keep silent, I don't want to inject the vaccine. And it's like become the big one to spreading the disease or the virus. That the psychological reaction in the general public. And when we talk the general public, another group is important when there is an emerging disease happen is the healthcare provider, right? When the healthcare provider is we can say we are the frontliner, have to deal with this disease, emerging disease, and we have to work hard for deal with it. And the way to psychological impact that is easier to make understand because we are nurse is will get a high level of state and feel fatigue, and the quality of life is very bad, right? Because for sleep, cannot eat in the easy way, some worry about healthy or today after work we will got the disease or not. And even though we know about the infected control method, but we still cannot say we confident and we can protect ourselves from that disease, that the psychological impact which occur in the emerging disease situation. So how to deal with it? How to deal with it is very easy way to deal. I thought every country there is the way to deal with the panic management, but today I just want to talk in like use the article and my experience in Thai when the COVID-19 come to Thailand and how to deal with it. And the key point of it is like we have to say about the psychological crisis intervention for deal with the panic management. To do panic management, the key point is like we have to do it for different group. Before I talk just the two group, right? The general public and the health provider. But when we want to deal to do the panic management, we have to do in the different group for make a detail, because every person when facing with the emerging disease is different factor and different kind of personality, and the factor around all of them is different to help. That's why we have to think about the different group and give the different intervention to each group. Today, maybe I didn't talk like deeply how to caring or how to give the nursing practice, something like that, because we just have the 30 minutes. That means I just is like a give overview for the method or the strategy how to do the panic management. The first step is important for like the organization, maybe it's public health ministry, or it depends on each country and each policy in that country. And we have to talk about the leadership. All these have to provide the necessary coordination and financial support, because we talked before, right? When the emerging disease happen, we will stay in uncertainty and everything is like not enough. It's shortage. Medical staff is shortage. The medical supply is shortage. That means the organization have to provide the financial and many kind of support. It can do it. Yes, surely the health provider can. It's like they have the power to deal. They have the support to help each other to help the people around our area in the country, in that country. And the second step, after we got the support, we have to prepare the guiding principle. The guiding principle is very easy way to think. I think it's like in Indonesia, there is this disaster many times, and we can use that guiding to use for like all this guiding for the psychological crisis, because the principle to do is similar, but just different the sort, the cause that the psychological from the disaster. But this we talk about the psychological problem which occur because the emerging disease that I thought you have it already. Just take it and bring it read again and make it appropriate with the emerging disease. For try to integrate the psychological crisis intervention into the overall deployment in the epidemic or pandemic prevention and control, and implement it, do it in appropriate in each group, not use the same intervention to deep into all the people because it's not appropriate and cannot help. It's will useless. That means we have to divide it and do it in different group. And the third step is mean you have to formulate the intervention plan that I talked before. It's like have to focus in each group which one this group want it and which one with this group don't need to use it. We have to make it appropriate by use the intervention planning. And for the step 4, try to make a team. Try to form a team. In Thailand, we have team is called name MCAT. MCAT is there is mental health care for the crisis situation. We have the team, MCAT team in every province. When there is the COVID-19 happen in Thailand, we have this team. They did go to every hospital and they taking care of each group in ward in different way and in the community in different way to keep caring, and they have like a team to taking care of the health provider because the health provider is important at that time, right? If we don't have the staff, the health staff who will taking care of the patient, that in Thailand we have that team to support the feeling, to support when the health staff feel fear, feel sadness, feel fatigue. We have that support for team. And if that team can evaluate, the health staff or the people who get the disease or show the mental health disease or mental health illness, they will have like the connection to consult the psychiatrist or the mental health nurse to help in the specific way. That the meaning of form team. That means not just only nurse have to, maybe we can become the leader of the team and setting team and make the coordination for to ask for help and manage how to help this one and how to help this health provider. And the last step is after we plan and prepare everything, we just working follow the method. And for the target which I talk to you in Thai we use this principle. We separate in 4 groups. The 4th group is like the patient who confirmed with that disease, emerging disease already. And the second one is like the frontliner medical staff or the frontliner disease control staff and the frontliner management staff. This is the first group which we have to taking care of in the way how to help when they got the panic or fear or some feeling bad when working and when they got the disease. And the second group is mean the group of the my patient. My patient is mean like that person is very close contact with the disease or some people got the disease. And the suspected patient is still half, is cannot show the disease or the symptom, but we know it's all very close. It's maybe that person will got the problem from that disease, that the second group. And for the third group is like the people related related with the first and second group. And the fourth group is the resident of the geographic area affected by the epidemic or pandemic, or the vulnerable people who are the affected in the epidemic prevention, something like that. That's the four group which we have to separate or divide it when give the intervention. And for the scope, I can say is just briefly to scope for how to give the intervention. In each group, we have to know that person which they will feel when they got that problem. The first one is the confirmed patient, right? The confirmed patient is mean they will feel denied, anger, fear, anxiety, abandon of treatment, or it's like a excessive optimism and high expectation about treatment. If we have to deal with this group, that means the important intervention must choose with support and make they feel like feel is comfortable to receive the
Sarah?
treatment. Yeah.
Would you please give me about 1 minute because it's a praying time for us?
Yes.
Just 1 minute, please. Thank you.
Okay. And for another one, another group is like my patient. We just think about what they present the feeling and give the intervention. The important thing is like a health education and encourage the cooperation and adaptation to change give to them. And the suspected patient is quite similar in the last group. You can read it in the slide. And for the healthcare and related personnel, we have the special one to give up them. The first one is have to rotate regularly because he feel tired and sadness and teaching they can do like a self-regulate and ask for help when they want. And another one for like the person who are close with the contact, we just like make they give the communication via the internet or some social network, something like that. And another is a patient who don't want to seek the medical treatment, just not criticize and support to the like explain and pursue in the correct way. And for the vulnerable people, and we just is like give the health education and eliminate the fear and prevention based on scientific evidence. And the important which I said, and I think you have the session to talk about this one to like the use the evidence base for facing. Yeah.
1 minute left, please.
Yes. And this one, the last line. And the social media is a important thing because like we got the misinformation, right? And after that, we have to manage it. If we can manage and give the correct information to all of the people in our country, that means we can protect can lead all of them to protect or prevent the emerging and reduce the panic feeling. That the way to do when we got the panic management. Yes, thank you very much for all of you attention in this session.
Okay, thank you very much, Ms. Chutarat, for your very interesting topic. And next, we still have one more speaker for this session. But because it's the okay, Professor Lisa McKenna, can you hear me, Prof?
Yeah, I can hear you. Yeah.
Okay, thank you very much, Prof. Lisa. Please correct me if I'm wrong in stating your name. Prof. Lisa, I think it's very close to Indonesia because her activity, many activity related to Indonesia.
Yeah.
Prof. Lisa, just briefly, I read your CV because you have so long CV. It's impossible for me to read all. You will lose your time. Prof. Lisa the interesting thing here for the audience, she could speak English and Indonesian very well because many activity in Indonesia, I think. She got the Doctor of Philosophy by 2005 in Deakin University, and the professional and related membership, many here, fellow Australia College of English, fellow New Zealand Association for Health Professional Educators, and still many other, and also external service roles here, also many. And I would read the interesting thing here that she also become editor of many journals in Indonesia. It's very interesting. And she also become keynote and invited presentation in Indonesia many times, especially in Universitas Hasanuddin, and then in Makassar, in Aisyah, Yogyakarta, and still many other places in Indonesia. I think in 2019, many activity of the professor in Indonesia. And then she wrote many books and book chapter here, of course, editorial and letters, and peer review publication, more than 5 pages that I could not read all. Yeah. So to save efficient time for Professor Lisa to deliver your topic, I would invite you, Professor Lisa, to give your topic using evidence-based in facing emerging disease. It's about 30 minutes. So time is just Professor Lisa.
Terima kasih.
Yeah.
Selamat siang dari Makassar.
Oh,
Saya
okay.
di Makassar. The
Okay.
hotel, the internet is not too good here, so I'm hoping it will be okay.
Okay.
Let me share my screen. So thank you firstly to the organisers of this conference for inviting me to present. I always love presenting in Indonesia, and I always get asked to do interesting topics, and I have to do a little bit of research to really be able to do that well. So I hope that today my presentation is interesting and will give another dimension to emerging diseases and how we face them. At the outset, I'm really going to focus on evidence-based practice and how we utilise that. Many of the other presenters have talked about some of the emerging diseases that we've encountered over the over the 21st century. So I think it's really important that, you know, we take that context and bring it in here. And I will talk about one or two, but really it's how do we use evidence to really help us in that practice. So I hope you enjoy it. So I suppose when at the beginning, one of the challenges we have when there's new and emerging diseases is that we know very little. And we practice based upon the little information that we have. However, these do provide us with really unique challenges in how we provide healthcare without not a lot of evidence to guide those. We've seen from COVID that we did not know a lot at the beginning, and as new evidence came to emerge, we started to adapt practice and know what was required. And certainly as vaccines came along, that made it easier for us. But we didn't know a lot about how it was spread in the beginning. There was lots of discussion about that. So until we had the evidence, we were not able to really implement appropriate practice. And we found that knowledge emerged very quickly, and it does emerge over time, but often we're using a very limited evidence base. And it does require us to be agile. We need to be able to adapt quickly and to be open to changing our practice as the evidence emerges. And I think one of the challenges for nursing, particularly when we're looking at emerging diseases, a lot of the evidence is medicine-based, and that's important, but nursing generally doesn't do a lot of research at the beginning. And often with COVID, for example, we were adapting very quickly to COVID and not necessarily thinking about the research that was specific to nursing practice that we needed to be doing. Oh, it's gonna let me. So when we look at COVID as an emerging disease, we know that it's been quite prolonged. It's obviously been international. It's affected every single country in the world, which is something unique for some of the recent pandemics that we've had. But knowledge rapidly evolved. And with that, there were new variants, and each of those variants had its own characteristics. And so we had to adapt and change as we understood more about the variants that were occurring. But it's really mind-boggling when you think about how much research there has been and how do you make sense of it all. So these authors identified, Ioannidis et al., identified that by the 1st of August 2021, there were 210,183 publications in Scopus about COVID-19. And I actually did a check yesterday or the day before and found that even just looking at titles and abstracts in Scopus, there were 366,553 papers on COVID. So that throws us a real challenge because clearly we can't read them all. And clearly it's very difficult to stay abreast of the literature. So it is challenging, and I think that really highlights the nature of some of these pandemics, and particularly in COVID, because it was international. We did see a lot of research emanating from many countries around the world, and even in nursing literature, there was an extensive amount of people researching and publishing around COVID. So it did make understanding and appraising the evidence quite challenging. And I have no answers to how you manage that, but it is quite astounding. So I think for me, it's really important if we go back to what we mean by evidence-based practice. And how do we, in the middle of a pandemic, try to utilise evidence-based practice to support our work? Evidence-based practice is around how we use current up-to-date research evidence to assist us in decision-making about how we deliver patient care. And it does require every single health professional to understand the current literature and what's happening, and to be able to understand the quality of the research that's out there. But evidence-based practice enables us to identify where we've got gaps in our knowledge, to go and find and systematically appraise the evidence, and I'll talk a bit about that. And evidence-based practice as a process has been described as requiring the relevant scientific evidence, clinical judgment, so knowing what evidence to apply in what situations is very important, and also evidence-based practice incorporates the patient's values and their preferences as well. And maybe in COVID and as that emerged, we didn't focus as much as maybe we could have on patients' values and preferences because we didn't understand a lot ourselves. So evidence-based practice is important. We know that healthcare knowledge is going to rapidly change, and particularly in an emerging disease. We need to be able to keep up to date and to refine our practice as the new data comes out. One of the challenges that we have is that consumers or our patients are more educated than ever before. They have ready access to data, and even with, well, particularly with social media, but in in COVID, lots of research was regularly being reported through the media, so that people knew often more than the health professionals who were really busy. The patients and their families often knew more about what was up to date than the health professionals themselves. We also know evidence-based practice is really important as we focus on patient safety and the quality of healthcare. And ultimately, we are responsible for those things. We have a responsibility for patient safety, and we have a responsibility that the care we deliver is of the highest quality. And I know even in the Indonesian curriculum, those concepts are now being reinforced. And so this is probably not new, but it's important to talk about. In an area where, being from a country, I'm from Melbourne in Australia, nurses have to hold their own insurance. And that's because there is a risk of, if we make an error, that you could be sued. So evidence-based practice is important to support the decisions that we make about our practice. And we can defend the care we deliver. And ultimately, it's part of being a professional, and professional standards require it. So what do we mean by evidence? So I've been talking about evidence for a little while now, but what is evidence? And there's so much out there that, you know, what can we use, what don't we use? So research studies, primarily qualitative, quantitative, mixed method studies, are all constituting evidence. It might be reviews such as systematic reviews, scoping reviews, rapid reviews, umbrella reviews. There's lots of different reviews out there now. Clinical practice guidelines and quality audits can also be evidence of the care we deliver. And you might have seen a pyramid like this one that talks about the level of evidence and the quality. So this is a really good diagram because it talks about where it identifies where the important quality research is. And you can see expert opinions at the very bottom because there's not a lot of substantiation there. It's really somebody's opinions rather than evidence. So we don't really work from expert opinion. Although it can be relevant, and particularly in such as COVID, we had a lot of epidemiologists who were very expert in their field, providing some information that was really useful for us. We can use, as we work up the pyramid, you can see that there's different types of studies. And at the very top, the highest quality of evidence is that of a systematic review that brings together lots of different research and synthesizes it. In the context of an emerging epidemic, you don't necessarily have time to do systematic reviews. So a lot of the research that was coming out during the COVID peak was really cohort studies, and that was the best available evidence that we had. So whilst systematic reviews might be the best level of evidence, it's really what you have available is the issue. And now we're starting to see the systematic reviews coming about because people are synthesizing COVID-related research now. So I think that it's really sourcing the best available evidence that you have at the time of the emerging disease. There's a lot of challenges in implementing evidence-based practice, and in nursing, these have been talked about a lot. One of the challenges for clinicians is that they might not have good knowledge of research approaches, so not necessarily able to determine what's a good study, what should I base my practice on, what do I need to develop, which ones do I get? You know, there's hundreds of thousands of papers out there on COVID. How do I know which ones are going to help me? Because so often the knowledge of research and the lack of skills in being able to appraise research is a block for many nurses, and not in Indonesia alone, but you know, internationally. And I think in the peak of the pandemic, nurses didn't have a lot of time to do reading. So that was also a challenge, and I think that probably, and the time pressures is one of those that's at the bottom. Often there's not, and it's been identified in a lot of research in nursing, that often there's not the organisational support for evidence-based practice and inquiry. And so healthcare institutions need to understand the importance of nurses doing evidence-based practice, because it's going to impact on the quality of the patient care that's delivered there. And the final thing that can be a challenge is sometimes there's not good evidence available at the time you need it. And certainly at the beginning of the pandemic, we didn't have a lot of evidence to base our practice. So we had to make decisions based upon the evidence we had at the time. I'm not going to focus on appraising evidence, but I think it's important that people practice appraising and evaluating the quality of research, that they look at how credible the researchers are, that there's a clearly defined research question or research aim, that the sample size, if we're talking quantitative studies, is representative. If we're talking qualitative research, that data saturation has been obtained, that when we're talking about quantitative studies, that we think about the confounding variables. Has the author thought of those and controlled for them where possible? Have they got the right research design to answer the question? And were their approaches reliable, valid, or in the case of qualitative research, were they credible? Did they use the appropriate data analysis, and is it correct? So sometimes that I find that data analysis is presented in manuscripts and it's actually incorrect. So, really looking at the detail. So knowing how to understand statistics is something that we have to be able to do, even if we don't like it. And have the researchers interpreted the findings appropriately, or have they increased their interpretations beyond what the findings actually say? And finally, most importantly, whether the studies conformed to ethical standards is really important. And that relates to all of the things about informed consent, ethical recruitment, protection of data and people's identities, and all of those sorts of things we need to start looking at. And it does take time to develop skills in appraising evidence. It's not something that's easy when you start, but I would encourage people to continue to have those skills to be able to do that. So one way to do that is to create a culture where evidence-based practice is normal, and that people are regularly engaged in research activity and evaluating research, starting to ask questions in a safe environment. Asking questions should not be threatening. It should not make people question their practice. It's there to make things better. Why do we do it this way? Where's the evidence? Have we got evidence to support that? Getting nurses to talk about research, to build their research capacity and their skills and their knowledge, and to remove some of the barriers that are there for nurses to do good evidence-based practice. Some of the ways that we can promote a culture that questions is by building what I call a spirit of inquiry and curiosity. So getting people to really think about, why do we do it this way? Is this the best way? What evidence have we got to tell us it's the best way? Is there newer evidence available? And in nursing, we often do things a particular way because that's the way we were taught, or that's the way it's always been done, not necessarily because it's got the best evidence base. So we have to start questioning everything we do about whether there's good evidence to support the way we work. And is a change of practice feasible in the setting? It might be that we do a particular task a particular way because it fits that setting better and we couldn't do anything else. So there's a whole lot of reasons, but it's okay to ask questions, and people should be able to ask questions in a safe setting. We also need to be talking more about research. And I think research for many nurses, and particularly once they become registered and practice, they graduate and they they become clinicians, it's not always something that nurses and other health professionals talk about. We need to encourage research discussions so that it becomes regular conversation. And we can do that through promoting research seminars. Some hospitals develop nursing grand rounds where they'll present a research study and talk about the challenges involved. We can use case-based learning, and we can use things such as journal clubs. So there's all sorts of ways in clinical practice where we can talk about research and make research a conversation. Certainly we know that happens inside bachelor degrees, in master's degrees, and we teach the skills in those courses, but often they don't transfer into long-term practice. And I'm talking from an Australian perspective here, but I suspect it's very similar in Indonesia. This is just an example of a study a systematic review that in nurse education today. So it's very much focused on nursing. It was done in the United Kingdom. And these authors explored the impact of journal clubs as one of the strategies for improving evidence-based practice. And they did a systematic review where they brought together different research on the implementation of journal clubs. And that their conclusions were that journal clubs were a really great way of encouraging people to read research and to start in a group to critically appraise research and to develop skills in that. So it didn't matter that they might not understand a particular aspect of the research, because somebody else in the group probably has that knowledge and can help them learn. So it's really learning from each other. It enabled them to increase their knowledge and their confidence, and was found to be a cost-effective way of developing staff in regards to evidence-based practice. And when we do these in Australia, some of our healthcare settings do these, and a particular ward will have a journal club once a month or once every couple of weeks, depending on their time. And certainly this was pre-COVID, I have to say, because they've been very busy since COVID. But they would choose a research paper that was really relevant to a clinical situation in their ward. So they could really unpick the evidence. It might be a patient with a particular condition, or it might be something that they did in that particular ward. So something to think about. Okay, so building research capacity. As I said, we know that our students are getting lots of learning around research capacity, and particularly in Indonesia, where students are actually engaged in research and they have to do projects. Our students actually don't have to do projects in their degrees. They do and in some master's courses in Australia, they don't either. So I think that, Indonesian education is really setting itself up well to enable people to develop these skills. But we need to ensure that everybody has the education to understand and appraise research and then apply it into practice. We need to be able to do research. And so there needs to be strategies in place for clinicians to drive research. And there's certain ways we can do that. Obviously, formal studies like masters and doctoral studies will enable people to develop those skills. Regular department seminars, workshops on research methods, and research methods are often changing, and mentoring in the space of research. So things like matching a clinician with a faculty member, so they can provide each other with support. The clinician can come with the research question, and the faculty can help develop the research around that. So building research capacity is really important.
Excuse me, you have 5 minutes left. Thank you.
We need to remove barriers. So we need to acknowledge that research for evidence-based practice is everyone's responsibility. We need to build a space for questioning and formulating research, making time in workloads, enabling peer support, giving people authority to implement change, even if it's just a trial period, and enable partnering between clinicians and faculty, as I just said. We can implement apply knowledge translation through project teams who work together to identify evidence. You could conduct a rapid review of the literature. You can assign articles out to people, use appraisal tools, make practice recommendations, and then identify implementation strategies for that. So knowledge translation is becoming really important part of evidence-based practice. And I think the important part around this is for groups of people to do that together, not just an individual person try and tackle it all on their own. Culture change is really important, and it does take time to change a culture. And even in Australia, you know, we're starting to do more evidence-based practice, but it does take time. It needs good leadership, and there needs to be rewards for successes and achievements, clear goals, and a shared commitment towards that culture change. So in summary, in emerging diseases, we know that healthcare knowledge changes very quickly. Knowledge generated by research changes what we know and what we do. Evidence-based practice is vital to quality, best practice, and defendable healthcare. All professionals need to understand research and how to appraise it, as well as to conduct research, and a culture that promotes questioning what we do is vital for ongoing positive change. These are my references, and terima kasih.
Terima kasih sekali Prof. Lisa for your very interesting speech. And evidence base is one of the thing in our education to improve our knowledge, experience, some others. Okay, Prof. Lisa, Ms. Chutarat, and but Dr. Lawrence, are you still here together with us?
Yes.
Okay, thank you. Now is the time for question and answer, and we have one question from the chat book here from Amelia Sarah to Ms. Chutarat. Ms. Chutarat, are you here? Hello, Ms. Chutarat, are you here? Not yet, or maybe she's taking a break, possibly. Because on the chat box, we only have one question, so I would give a chance for the participant already raising hand here. We have Mr. Abhijasetrofi. Is that right? Still mute. Mr. Api Yazid-Rafi still mute. And the second, we would give the time to Ms. Dwi Puji Hastuti. Ms. Abi, are you ready to deliver your question? You can turn on your mic. So would you like to write on the chat box, please? Then we give the chance to Ms. Dwi first. Dwi Puji, would you like to do?
Okay.
Oh, sorry.
Oh, yes. Thank you.
Mr.
Abi,
okay. Yeah.
Thank you very much. My name is Abi. I am a student, PhD student from Chulalongkorn University. I would like to ask Professor Lisa. Thank you very much. It is a very interesting topic about evidence-based practice. I would like to ask about if we in the situation like the beginning of emerging situation like COVID-19, according your opinion or your point of view, how we should do the evidence practice when we still maybe don't have any evidence, we don't have any quality research or something like that. So what should we do if we are on the situation, the beginning of the emerging situation? Thank you very much, Professor.
Okay, Professor, you can what Mr. Happy asked you.
Yeah.
Yeah,
Can I
okay.
answer?
I'm yours.
Terima kasih. That's a very good question. And I think that's one of the challenges as things like COVID-19 emerged, the quality of evidence wasn't good. And so we had to use the lower level evidence that we were getting, so that expert opinion from predominantly from epidemiologists who still didn't know a lot. We had to utilize a lot of that type of evidence because, you know, it also takes time for evidence to become available. You know, we know the publication times can be quite long. And so we have to use the best available evidence that we have. And so a lot of the studies were quite small, and a lot of it was very scientifically based because nursing took a long time to get evidence into place as well. I think it is one of the challenges in something like COVID, when you have a pandemic, that you have to find what evidence there is and then make decisions based upon what you have. So yeah, you don't have the expertise of systematic reviews at that point. You've got to use the quality that you have at the time. And certainly I know in COVID that was a real struggle for people because we didn't know. And so we were assuming some things and they weren't necessarily right. And I think early in the pandemic, there wasn't really an understanding that it was so airborne. And so, you know, once we learned that, we had to adapt again to our practice. So yeah, I think that's one of the challenges, and I don't think there's an answer to it. But thank you for the question.
Okay, thank you, Prof. Lisa. I think what Mr. Abi has also experienced, in all of us also experienced about this issue as well. Okay, I would invite again Ms. Chutarat. Are you here, Ms. Chutarat? Hello? Maybe this is not joined yet. Okay, so next we would give a chance to Ms. Dwi Puji. Please state where you come from and what the question you point to. And now time is yours.
Okay. Thank you, Mr. Widodo. Question for Mrs. Lisa. Hello, Mrs. Lisa. Nice to meet you. I'm Dwi Puji. I come from Polytechnic Surakarta. I want a question asked to you. Are there any specific rule for the many sample required research results can be used? And give me the last sentence statement for closing for our nursing student, so we can make research to culture. Thank you, Lisa.
Terima kasih. The audio was a little bit unclear, so I'm hoping that I answer your question okay. I think it's similar to the last question in a little bit of ways, because we do have to have the skills to understand the different types of evidence that are out there and available to us, and understand how that emerges, and then also to understand how to then apply it. So what does that mean for our practice? So I think that's the goal around, you know, evidence-based and really having that understanding of research and how it works. And I know in Australia it's challenging for clinicians to be on top of all the research in the being very clinical practice, faculty and clinician, and also to drive a culture from within the healthcare organisations themselves. So to have people who are willing to drive that be challenging too. I've talked about a lot of challenges, haven't I? Has that answered your question?
Could
Okay, I think enough.
Okay.
Maybe.
Okay, thank you very much. Okay. All right. Once again, Ms. Chutarat, are you here? Not yet. Okay, so the next chance would be lucky to Mas Jaki Abdul Koni. So you have a chance to state your question to whom, and okay, time is yours.
Okay, thank you, Mr. Widodo. I'm Zaki. I'm from Polytechnic of Surakarta, and here I would like to ask to Mrs. Chutarat from Chulalongkorn University. I would like to ask about.
Sorry, Jaki.
Yes.
Are you asking to Ms. Chutarat?
Yes.
Unfortunately, up to now, Ms. Chutarat is not here.
Oh.
Not yet. Hello, Ms. Chutarat, are you here?
Yes.
Okay.
Okay.
Okay, let's continue. Jackie.
Yeah.
Okay, nice to meet you, Mrs. Chutarat. Here I would like to ask, because of the COVID-19 situation, like all of the activity are changed to online platform, like mostly like we are as students, like adolescents and young adult in the college, move from the offline platform to online platform, and these changes are causing some health-related problem. And when now we have relaxation in the health protocol and we can go to the college for their study, but sometimes some students also feel that they have comfortable with the online platform itself. So sometimes they feel hard to make an adaptation again to go to the college for the offline class like this. So what I would like to ask is about what kind of intervention or maybe some support that we could give to the students so they could make good adaptation when they back to the college because this online online learning. Thank you.
Okay, thank you for the question. It's a nice question. And for me, I thought it's like this is quite I can say it's a different on each country for like the student situation have to studying via online, right? And you asking when they back to like on-site study again to on-site, how to give the intuition is like how to make the adaptation in this situation, right? Is this like if we want to talk about this, we have to say about what the it. If talk about the student who studying in the university, I believe that is they can adapt themselves. It's easier that the teacher have to trying like don't force them in the way like the same time, because now they learn the new normal to studying. That my experience. It seems like my nursing student, they quite familiar the way to studying via online, and they can make it like independently free when studying and don't need to do many things when meet at the conference or the meeting via live. They feel free. And after that, have to back to the basic on site. They have to prepare everything, books, computer, and dressing up, blah, blah, blah. And they think like, oh, it's why it feel bored. It's like when meet at via the online, it's just like open or sometimes it's like just close the camera. It's okay, but still can studying. But for me, there is two things for the student that try to adapt to become like okay, if still have to go on site in some subject, just try to adapt or adjust your behavior. But for the teacher, maybe have to change the style to teaching some subject or some detail, maybe can change to become used to the online, because now we are familiar and we cannot say it's effective or not effective, but can use it like a mix together. It seems like now Chulalongkorn still use the both way to studying online and on-site. That will can help to like reduce the stress for the student and also the teacher too. Because when work online, it's some teacher think it's like it's easy to deal because it can manage time. Some teacher is like in the night and the student is like because that that they like to learn in the night or something like that. That means have to find a middle way to talking and communicate by under the policy of the university. That know the intervention that like to do in the appropriate way with the student wanted and the teacher wanted. That's my opinion. Yes. I'm not so sure I answer your mind.
Okay. All right. Thank you, Ms. Sutarat. Okay. Ladies and gentlemen, the very limited time. Now we already come of this session. So I would like to say thank you so much to Dr. Lawrence Salamat, to Dr. Lawrence, and then Ms. Sutarat Sawadikap. Thank you very much. And also Prof. Lisa, thank you so much. Terima kasih for your time given to us to share for your knowledge. I think all of the speakers already the topic, and we come to very end of this session. Thank you very much all, and see you. Terima kasih. I'll give back the time to MC.
Thank you, Mr. Widodo, Master of Nursing, for guiding the second plenary session.
Ladies and gentlemen, now we are going to third plenary session. The third plenary session will be guided by Mrs. Dwi Puji Astuti as Nurse MCAS as moderator. Please welcome Mrs. Puji Dwi Astuti as Nurse MCAS.
Okay, thank you, Mbak MC and Mas. Okay, selamat siang. Yeah, good afternoon. Ladies and gentlemen, welcome to session 3. I will get this session 3. Before we begin, I would like to introduce you the speakers. We have 2 speakers in this session. Okay, the first speaker is Sri Mulyanti from Surakarta Health Polytechnic, and the second speaker is Mr. Randy Adyat Hermawan. Without further ado, I'd like to welcome our speaker to start the presentation. The first speaker is Mrs. Yanti, work experience 1998 until now. She is lecturer head of Polytechnic Surakarta, and then educational background 2003. She is Bachelor of Nursing Gadjah Mada University 2011, Magister of Nursing in Airlangga University, and 2021 until now underdoctoral program at the Public Health Science 11 Maret University. She will bring topic about redness and constraints in facing stunting. Okay, Mrs. Yanti, are you there?
Yes, okay.
Okay.
I give you 10 minutes for presentation.
Okay.
Time is yours. Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Yeah. Waalaikumsalam warahmatullahi wabarakatuh. Okay. Thank you about the time. Sudah kelihatan. You can focus on screen sharing. No, yeah, it's okay. It's clear. Yes. Okay. Thank you, Ms. Dwi Puji, as moderator. So I have 10 minutes, Miss. Yes. Okay. Thank you for everyone for the join in the meeting. So firstly,
We must say thank you Allah subhanahu wa ta'ala. Because of Allah, we can join in the conference with good condition, healthy, and happy, so on. Okay. The second, salawat and greeting always say to Muhammad sallallahu alaihi wasallam. Because of him, especially we're Muslim, he gave away guide to life. Okay. I want to explain about my topic. Maybe review about the topic readiness and constraint and facing stunting in Indonesia. Okay, I can explain about the concept maybe. For example, definition and etiology, and maybe the strategy to decrease about the stunting. Okay, I believe all of you know about the stunting. Okay, we can next to the definition. Stunting is the impaired growth and development that children experience from poor nutrition, repeated infection, and inadequate psychosocial stimulation. And then children are defined as stunted if their height for age is more than 2 standard deviation below the World Health Organization Child Growth Standard Media. Okay, as a health worker, we must know about the importance of golden period of 1,000 first days of the growth. Okay, because of that, we can give a contribute to decrease incident of the stunting in Indonesia. Are you agree? Okay, I think agree about that. Okay, and then you know that stunting have correlation about growth failure, immune dysfunction, and then impaired cognitive development. We know have many problems about the case. For example, dietary insufficiency, for example, macronutrient deficiency, and then micronutrient deficiency. And microbiome dysbiosis, for example, pathogen exposure, and inadequate diet, so low immunity, and then antibiotic. And then finally, pathway changes, for example, chronic infection, pro-inflammatory signaling, and then enteropathy condition, for example, environmental enteric dysfunction, and then human immunodeficiency virus infection. So according all of the etiology, cause nutritional enteric failure. And then maybe for in the intranatal condition can cause premature or small for gestational age. Okay. And then you know that story highlight in Indonesia. Stunting is still a problem of child nutrition in almost all the world, including in Indonesia. The Indonesia Nutrition State Survey in 2021 shows that the stunting rate declines from 20.8% in 2018 to 24.4% in 2021 in the country's 23 million children aged under 5. Okay. Indonesians to work hard and work together with the government to lower the stunting prevalence rate to 14% from 24.4% in the next 2 years. So very hard. Okay. Yes. Okay. The equal about the topic 16th Interprofessional Nursing Conference, the improving of national health system in facing emerging and catastrophic disease through 6 pillar of the health transformation. So, equal about the Ministry of Health of Republic Indonesia is committed to improve health system transformation. So, we have 6 pillars of health transformation. The first, primary care transformation. The second, secondary care transformation. The third, health system relationship transformation. The fourth, health financing transformation. And the fifth, health talent transformation. And the last, the sixth pillar, the sixth, health technology transformation. About my topic, readiness and constraint facing stunting, include in the first pillar, primary care transformation, especially for point C, secondary prevention. So we know we can see a screening for 14 leading disease causing death in each age target, and then stunting screening. So it's included as my topic here. Okay, and then how about the progress in the stunting treatment in Indonesia? The government of Republic of Indonesia has targeted that by 224, the stunting rate will only be 14%. And then achievement of this target is continuously evaluated. Indeed, until 2021, data shows that the incidence of stunting in Indonesia continues to show a downward trend. Okay. Yes. Oh, okay. Even 2020, the stunting rate was still at 37.2%, then it decreased to 30.8%, and in 2021, it's decreased to 24.24%. Okay, and then we know that from 2013 until 2021, we keep change situation stunting significant. You can see about data and stunting figure in Indonesia compared from various sources. Okay, and then the government of the Republic of Indonesia has targeted that by 2024, the stunting rate will only be 14%. So I think we have more homework, yes, to get the target, and we must need hard work. Maybe all of the hard worker can collaborate, and interprofessional collaboration to decrease about the stunting. Okay, and then the causes and risk factor stunting in Indonesia are what we call constraint. We have 4. The first, poor babysitting practices, and then limited health services, especially antenatal care, and then lack of household and family access to nutritious food, and then lack of household and family access to clean water and environmental sanitation. Okay, all of the problem is confused. Yes, is make me the influences about the problem for family, economy, social culture, environment, and health states. So many factors to influence it about the constraint the stunting. Okay, and then strategy for handling stunting in Indonesia. 2017, the Secretariat of the Vice President of the Republic of Indonesia have the program 1,000 priority district or cities for stunting intervention. And then the 2018, the Ministry of Village Development of the 17th Region and Transmigration village pocketbook on stunting management, and then Perpres Presidential Regulation number 72 of 2021 concerning acceleration of stunting reduction. Okay. And then,
Sorry, Mrs.
yes, okay. Thank you about the time. I'm sorry, Miss. Okay, Assalamualaikum warahmatullahi wabarakatuh. Okay.
Waalaikumsalam warahmatullahi wabarakatuh. Okay, sorry, Mrs. Yanti. I will the next discussion. Okay. The last speaker is he is Mr. Randy. Okay, Mr. Randy, are you there?
Okay,
Okay, Mr. Randy, he is a lecturer in Poltekkes Kemenkes Surakarta, and then Bachelor of Nursing in Airlangga University, and Master Program of Nursing in Diponegoro University. Mr. Randy, I give you 10 minutes. Okay, time is yours.
Thank you, Miss DP. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Good afternoon, everyone. How are you today?
Hello, Mr. Randy. Fine.
Okay. I look some people in this room eat together. So you can shoot the situation in this room. Okay. Please shoot. Please shoot. Yeah. So I'm in out of Polytechnic of Surakarta, not only as lecturer, but Mr. Director give me another job as Commandant of Task Force COVID-19. So when you eat together in the first time of pandemic, I will angry with you. So, but in this afternoon, situation is different because I believe all of the students, all of the committee in this room have finished to get fully dose vaccination. I think you get more than 2 dose vaccination, maybe until 3 or 4 dose. So if we back to the first condition in the pandemic COVID-19, we don't get vaccination, and then we don't have immunity to facing with COVID-19. But when a lot of number case COVID-19 in Indonesia, and then supporting by vaccination coverage in Indonesia more than 80%, I think we enter to endemic phase because we have herd immunity today. So I will share my material. Okay. Today I will explain my material about the role of academic as role model and community managers in dealing with emerging disease. Not only we have job to make you smart student, but also we have responsibility to become health educator, to become community manager, to become role model. Because not only COVID-19 pandemic, but also emerging disease in the future will be more variative. So if we look at to our history, the first in 2018, Indonesian find the first case about yellow fever, and then in the August 2022, first case for monkeypox is found in Jakarta. So what is our role as academic community? Nah, if we look at the flag map, it's a flag map for Garuda Indonesia plane. Many routes to Indonesia come from another country, so it's easy to disease come from another country come to Indonesia. So we must readiness to facing with emerging disease. And then the question is, are we ready to facing the pandemic in the future? And then are our health worker, facility, drug, vaccine, and community habits already to facing with emerging disease? Is the question must be answered by ourselves. So the government through the Ministry of Health has learned from the COVID-19 pandemic. As we know, when COVID-19 pandemic, all of hospital is fully, not only in the permanent hospital, government must build the emergency hospital because our facility is not enough to facing with emerging. We know already to facing with COVID-19. So after that, our Ministry of Health transforming the health system, and then this program is carried out to better prepare the community and the health system to facing pandemic in the future. And then the first transformation is primary care transformation. So our government want to, our community is already to facing emerging disease in the future. Because if only government already, but our community don't care with the effort to prevent the emerging disease, I think it's impossible to we win the fasting with emerging disease. So what must we do? The first is education to population. If we look at and learn during pandemic COVID-19, not all report for WA group, social media is true report. We must passing with books in our community. So as academic community, we must share the true report, and then we must change the perception of community about the false report. And then in the second is primary prevention, and the third is secondary prevention. And in the fourth is improving capacity and capability of primary care. I think our program to become role model and the community manager is include to primary care transformation in the first transformation of Ministry of Health. So what is our advantage as academic community? Oh, I think I hear a child phone, so it's screaming. Okay. Many people ask to me about effectivity, safety, and then risk for disease after vaccination. And when I only tell to them without evidence base, without journal, without report from government, I think they don't believe with my explanation. But when I tell to them with evidence based, with journal, how many effectivity about this kind of vaccine? How about the safety of vaccine A? I think they will believe. But if we cannot to tell about the journal evidence, I think our community cannot believe with our explanation. And then we have appended in the library resort. Not all of community have access to journal, to information, to internet, and other valid information. And then academic community can get it. And the second is ability to analytic. So science the student, all of student in front of me always trained by critical thinking, by analyze the case. So usually we always analyze the case, and then I think we have good ability to analyze. And then the third is trust by people. Our community like with our experience because they believe we are smart people, because we have high education, and then community trust to our explanation. And the fourth is ability to explain. Science student, I think you always to in front of the class and then give explanation to your friend. And I think it's easy to help worker to explain the program for community, because we always train education method to in study.
Sorry, Mr. Reddy, 1 minute again.
Okay. Whoa. Okay, the 6 is the mid-love of people, and the 7 is flexible working time. And then, how do we define a role model? Role model must be smart, must be creative, disciplined, not only for small people or the people level lower than them, but in the upper level we must discipline. So I think we can next to next slide. So how about role of community manager? So I have philosophy like Sun Tzu. If you know the enemy and know yourself, you need not fear the result of 100 battles. So the keyword is we must identify our ability, and then we must identify ability our enemy. So I think we will win the fighting. To identification, we must listen more, not only give suggestion. You must like this, you must like this, you must like this, but also you must, what do you want? What is your condition like this? So we must listen more. And then lead by example. Not only talk, but we do. Team player, not single show. And then we must ask, inspire. We can facilities. How does the affect the team and support? Okay, I think we can move to this slide, and then what we do in Health Polytechnic of Surakarta. We create instrument need assessment for COVID-19 for the first situation, and then we get data, and hosting facility is 23 people, and then 100% student in the Health Polytechnic of Surakarta get socialization about wearing mask, washing hand, and special planning. And then we have COVID-19 task force. So the second assessment is risk factor for COVID-19. And then only less than 1% people in Health Polytechnic of Surakarta have high risk to infect by COVID-19 pandemic. And then after that, we create open recruitment. We create services for psychological triage and other services. And then the most important step to facing COVID-19 is vaccination. And then we learn to Banyumas dormitory. Banyumas dormitory get infect COVID-19 more than 150 students because they don't have early warning system. And then we create early warning system in this school. We create about Google Form, and then KSR must be checked about risk factor for COVID-19 pandemic, and then we must learning by online. And then when we meet together like this, we must save about health protocol. And then what is the result for our effort? The first is 0 incident that due to COVID-19. If we look at to another instance, another university, not only 1 or 2 people die during COVID-19 pandemic, but in Poltekkes Surakarta, alhamdulillah, 0 incident of death during pandemic. Okay, and second is okay, maybe 1 minute again.
Finish, Mr. Raimi. Time to discuss.
Okay, I think that's all. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Okay, for all participants, if you question for speaker, you can chat room or raise hand. And we are discussion about stunting and COVID-19 role model in academic. Mrs. Yanti, are you there? Okay. We will discussion about stunting. Okay. As a result of the COVID-19 pandemic, the economy is down. Okay. How to improve the nutritional status of children while buying food costs with money.
Okay, it's a difficult condition, yes, about the pandemic COVID-19 is adverse effect about the family, and then maybe the family lost work, and then so influence about the how many the household or her mother to take nutrition about the children. And then so we can discuss about the mother and household to maybe how about the knowledge about the good nutrition. And then we can discuss about how food local, maybe Miss, Miss JP, local food good nutrition to increase about maybe the children interest about the nutrition, and then so we have more strategy to how about the good nutrition when give improve about the berat badan, so weight about the age, weight about the children, and then maybe start from how about the household make the cake, maybe so must be hygiene, and then compare about the some what we call bahan, yeah. So and then how about menyajikan? How about how about the clear? How about to children? Yes, so can improve about the weight, and then knowledge about the household and family to good nutrition must be improved to mass media, maybe, and leaflet about the good nutrition. And you know that until now, maybe not only know how and good nutrition is mas high, mahal, Ibu. Expensive. So we must know that many various nutrition and good nutrition to the child to improve about with the child, and must be know how about the mengolah. I think that is Miss. Yeah, I'm sorry about my language. Okay.
Okay, thank you, Mrs. Yanti. No problem with your language. So, ini ya. Jadi untuk mendapatkan gizi yang baik itu tidak harus mahal. Good food does not have to be expensive. Benar ya, Bu ya?
Okay, I think so, Miss. Okay.
Mr. Randy, are you there?
Okay.
Okay. Mr. Randy, topic about the role of academics as role model and community manager in dealing with emerging disease. Mr. Randy, the role of academics. Yeah, the role of academics a role model. So you can get a constraint in the role model and community manager in dealing with emerging disease. Focus in COVID-19.
Okay, thank you.
Pandemic situation.
Okay.
In 2 years.
Okay. Thank you to Ms. Depi for the example. Constraint during pandemic COVID-19 is inviting students and our lecturer to wearing mask. Not all students and our academic community agree with wearing mask because they have many reasons to not wearing mask. For the example, sir, I don't want to wearing mask because I cannot breathe easily when wearing mask. And then in second, I buy many expensive lipstick to make my lip red. So when I close my lip color with mask, I think my boyfriend cannot look my beauty face. And then the third, I ever special case. Sir, I want to join in beauty contest. I want to join in beauty contest. When I wearing mask, so how about my score? How about my score? The jury cannot see my beauty face. So I think the important in pandemic situation is the health condition, and then beauty face is the last value, and the important value for this situation is healthy condition. I think that's all. So we must consistent to socialization, to inviting people to wearing mask. Okay.
Thank you, Mr. Randy. I'm a survivor, and Mr. Randy, I think he is survivor too of COVID-19, right?
Of course, we are one heart.
So I think heart is everything. Sure.
Okay.
Heart is everything. Wearing mask is this year and next. This usually wear mask, but in the room lonely, I think no wear mask is no problem. But in the much people, we must wear mask, right, Mas Randy? Okay, I think Miss Yanti and Mr. Randy give a closing statement before close session, please.
Okay.
Mr. Randy or Mrs. Yanti.
Okay. Thank you, Ms. Tripuji. Okay. Now stunting is a problem or just not a hard worker, but all of the people in Indonesia. So we must increase. We must increase about collaborate and include in hard worker and maybe another. So I believe we can participate to decrease incident of stunting in Indonesia when we increase about the collaboration. Okay, Ms. Jeffrey, thank you.
Okay, thank you, Mrs. Yanti. Mr. Randy, you can give a closing statement before close session, please.
My closing statement is, it's not a matter of quantity. We don't need to many people to move, but how we can make they move. And the second is, the best human are those who are useful. We must support our community, not only think about ourselves, but it's more than this. And the third is, don't follow the path of crowded, but you must follow the right path. I think that's all. Thank you.
Okay, thank you, Mr. Randy and Mrs. Yanti. The great topic today. Have a nice day. So I will take Mr. Master of Ceremony.
Thank you, Mrs. Dwi Puji, for guiding the third plenary session.
Ladies and gentlemen, now we are going to the fourth plenary session. The fourth plenary session will be guided by Mrs. Insiah, Master of Nursing, as moderator. To Mrs. Insiah, the time is yours.
Okay, thank you very much for chance given me. Good afternoon, everyone. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi.
Okay, this is the last session of this sixth International Nursing Conference of Health Polytechnic of Surakarta. And before we start, I will introduce myself. My name is Insia. I'm a moderator for this last session. And before we start, I will check, or maybe I would like to say hello to the speaker for this session. The first is Professor Zahra Saad. Hello, Professor. Hello, Professor.
Hello, Assalamualaikum.
Waalaikumsalam warahmatullahi wabarakatuh. Nice to see you, Prof. Zahra. Okay, thank you. You already joined in this meeting. And then next, Bapak Adi Mardi. Hello, Assalamualaikum, Pak Adi.
Waalaikumsalam warahmatullahi wabarakatuh. Selamat siang, Bu Insia. Good afternoon, Prof. Zahra.
Thank you very much. Already joined in this meeting. And also the third speaker, Ms. Abigail K. Green. Hello, Mr. Green. Are you here? Hello. Good afternoon. Hello. Mrs. Green, are you here? Maybe still not connected. Okay. Firstly, I will ask to Master of Ceremony. Can we start first? We already together with two speakers. Okay. During we wait for Miss Abigail K. Green, I think I will introduce, or I will read the curriculum vitae of Prof. Zahra and also Pak Adi. First, Prof. Zahra. Okay. This is Prof. Zahra Saad, the Dean, Faculty of Nursing and Midwifery, Masa University in 2005 to 2019. And Director of International Relations Academic Advisor Nursing in 2020. And she already followed the long learning from short course to PhD. And right now she already as a professor. And also he also the member of association and professional membership. There are so many here, and I can read for you some of them. From 2010 to today, in reappointed as panel of Malaysian Nursing Board, and also 2003 to today, panel of Curriculum Committee Nursing Board, Ministry of Health, and then also 2010 to today as a chairman Al-Falah Z-Care Nursing Home or Daycare Center. And also in Global Nursing and Midwifery member from 2008 to today, and panel of Malaysian Qualification Agency from 2012 until today. And there are many things for activity for Prof. Zahra, and also many presentation and also community projects. And something that really important for us to hear about this as patient, persistent, and perseverance. As a Dean Faculty of Nursing and Midwifery of Malaysian Allied Health Science Academic, Masa University, and member of Malaysian Nursing Board, and also chairman and main thing. And of course, from Prof. Zahra, we will learn more. And for Pak Adi, I also will read the curriculum vitae of Pak Adi. Adi Mardi Harnanto. He graduated from the University of Melbourne, Australia in 2003. And right now, he is Secretary of Department of Nursing and head of the Diploma for Nursing Study Program at Surakarta Polytechnic from 2007 to 2014. And then for the educational background, he started the education from Diploma 3 and then continue to Bachelor of Nursing with honor in Australia, and then continue with Master of Nursing in the University of Melbourne, Australia, and also get certificate of English for academic purpose in Trinity College, Melbourne, Australia, and then certificate of nursing curriculum in Japan ASEAN Youth Friendship Program in 2005. He also has many publications and also participate in organization, especially in PBNI, or the Organization of Nursing in Indonesia. Okay, now I will say hello first for Mrs. Green. Are you here? Hello, Mrs. Green. Okay, not yet. Okay, ladies and gentlemen, we will start with Prof. Zahra, and we give you 30 minutes for presentation, and then followed by Pak Adi for 20 minutes. And then during we wait for Mrs. Green, we also can conduct a discussion. And for the participant, please you write down your question if you have question through the chat room, and then we will read for you after finishing the presentation. Okay, Prof. Zahra, this is time for you for presentation. Thank you.
Thank you. Sorry. Can you hear me?
Yes, Prof, we can hear you. Yes.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Waalaikumsalam warahmatullahi.
The chairman and the organizing scientific committee. First of all, let me thank you for this kind invitation. It's an honor to be together with the rest of our colleagues to share our experience and professional knowledge. And I am delighted today. And thank you for make some adjustment, because in the morning I have one accreditation panel, and we have, as you know, in any program there will be a panel of accreditation to come and validate our program. So this morning we have one post basic gerontology accreditation. So with the kindness of your organizing committee, change my topic to deliver sharing in the afternoon. Right now, can we have the sharing, the screen sharing, please? Is it okay? Can the person, the coordinator, share with me the screen? As the topic given, yeah, while waiting for the screen sharing, can yeah, okay. Yes, the theme today is improving the national health system in facing emerging and contemporary disease through evidence-based and 6 pillars of health transformation. Timely, and is really what they say, a contemporary topic now, because as we know, pandemic large-scale outbreak of infections disease that can greatly increase mobility and mortality over a wide geographic area and cause significant economic and social and political disruption. Yeah. So evidence-based, like what we hear this morning, evidence suggests that the likelihood pandemic, all these are during the past can cause increased global travel and integration. So now with this trend likely will continue and will intensify significant policy attention as focus on the need to identify and limit emerging outbreaks, and that might lead to pandemic and to expand and sustain to build preparedness and health capacity. This is what the team on the 6 pillars of the health transformation. So let me just reflect on the 6 pillars as what as written there, because these 6 pillars, we as the health care professional must be aware, and we want to understand, and these 6 pillars is the structured around the WHO framework, and also describe health system in terms of 6 core components of building block, like service delivery, health workforce, health information system, access to essential medicine, financing, and leadership governance. So since I am from the academician background, my topic, I will be focusing more on the education and also training with regard to the topic given. And the next slide, please. Okay, just go the slide that first, second one, this on the screen now. When we talk about the care management, because the topic that given is more the management of care patient with catastrophic disease. And when you talk about this, we have to understand that care management is a set of activities intended to improve patient care and reduce the need for medical services by enhancing coordination of care and eliminate duplication, and helping patient and caregivers more effectively manage health condition. We listen to the rest. I also been following on the few topic this morning. Everything we talk about pandemic, and we talk about how to take care. And this set of activity, of course, we want to improve patient care and reduce the need for medical services by enhancing coordination of care. So we talk about the teamwork, we talk about the other healthcare professionals. Yeah. Okay. Let us go and focus again on the topic that given to me. So the next slide, please. So the topic today for today topic, management of care patient with catastrophic disease. Okay, let us see how component of comprehensive care in the management system here. Yeah. So before that, I just want to go through the international community. When we talk about pandemic, we talk about outbreak. This is really a few topic. Is not only when we talk about pandemic on the COVID-19. As what we listened earlier, we have also pandemic like the first cholera pandemic in 1817. The speaker mentioned. We have also Asian flu. We have Russian flu, MERS, yeah, chikungunya, and also dengue. We have also Zika virus, swine flu, and also with the recent pandemic, we have COVID-19. Okay, so with this, how the 6 pillars come in with the 6 pillars of health transformation, how the service delivery, how the health workforce, how the health information system, how to access on this access to essential medicine, and how's the financing, and how's the leadership and the governance. So we want to discuss and come up with the good idea in the collaboration and integration to the best, yeah, because at its highest level, care management in healthcare is a natural extension of primary care. It starts from the primary care to make that ideal a reality. So this is a comprehensive care that management program requires a complex coordinated interplay among all healthcare stakeholders, from practice, health system, and care team to caregivers, patient, and the rest. Yeah. Okay. So this is again to me is the right team. Congratulations, and something that we have to go in and out, and we want to discuss further. Since I am from the education point of view, academician, so my point is more towards the educational point of view. How about the view from the teaching staff and also the managerial and also the leadership? Okay, so what is the most important that we must know here? Can we go to the next slide? As a academician, as a trainer, as an educator, you must also aware that there are few concern from the student when we talk about this management of care patient during this category or during this pandemic situation. The student, because I am trying to be prepared them for the better product, for the quality product in order to manage care in future. So we do not want them to have this kind of fear, because when we prepare them, we want to prepare them for the best, for the quality graduate. So I am sure some of the participants there, I am sure there are many student nurses there, fear of getting COVID during the clinical practice. Maybe you can write in the chat box. What do you think? Whether you are prepared enough to go to the clinical practice while this pandemic, and some of them, they feel not competent enough to treat patient with the knowledge and skill that they have. So that is also, we want to make sure we prepare our workforce, health workforce competently, and be caring enough to take care of this patient during the pandemic. So the research and the evidence, of course, the pandemic of this COVID-19 just happened. Is of all sudden, with the last 2 years, we did not prepare enough. So the research and the evidence is insufficient, even though the research this morning show that in the Scopus, there are a lot of more than 370,000 abstract related to the topic on evidence base. But of course, not much on the pandemic. Like what we said, the research and evidence is insufficient. Thus, have different opinion regarding the guideline and how to take care of patient with this catastrophic disease. Yeah, okay. So fear to interact with people due to long period of isolation, that also happening. Yeah. So now the care management, according to report from the Centers for Disease Control, and these services activity that help patients with chronic complex, we must also ensure whether we have a good team like physician, clinician, and caregivers, because all this we must work together to help patients take control of their complex health needs in future. Okay, next, can we go to the next? Okay, when talk about care management, is a promising team-based, patient-centered approach designed to assist a patient and their support system in managing medical condition. So now we are preparing, let's say, our workforce, when we want to prepare our nurses to take care this kind of patient, are we prepared then enough? We talk about workforce. We are here to prepare them with a complete, professional knowledge with regard to the nursing science, with regard to the health science, with regard to the nursing skills, and also attitudinal. That means the nursing, the cognitive level, the psychomotor level, and also affective level. And with that also, don't forget, the professional knowledge is very important in terms of preparing with the health science nursing science, and behavioral science. When come to the hands-on, whether they are really equipped and prepare them with the nursing skill, how to take care of this patient during the pandemic. Everything must be there in terms of training and from the point of the education. So when we design this training also, we must understand we don't compromise with quality. Yeah, okay. So when we said we don't compromise on quality, and remember the nurse there, all our nursing students, all our future graduates, a nurse, you remember as a healthcare professional, you are the future nurses. A culture of safety is a journey, and we must take care of our patient with regard to safety, patient safety. Yeah, remember. So whatever you take, you must have this culture of safety. Because remember, a culture of safety is a journey, not a destination. It requires a continuing diligence. That's why with that 6 pillars of health transformation, whatever we do, a culture of safety should be the focus. Okay, our service delivery, our health workforce, how we must instill importance of culture safety. We must have the how inform of a health information system, how they access the to essential medicine or the preparation of the psychological preparation. So this is what I am talking about, the preparing our nurses in management of care patient with this category disease. Okay. Now, catastrophic disease is a part like pandemic here, as I mentioned earlier, pandemic, a large scale outbreak of infectious disease. So now, when you already study in the classroom on the certain disease, certain communicable disease, now you are going to the clinical area to practice, to apply. So in the nursing discipline, you have to remember, you have to apply your theory well. So in nursing, theory and practice illuminate each other, meaning that theory and practice illuminate each other. And without theory, practice is unintelligent. And without practice, theory is not understood. So theory and practice illuminate each other. When we study on the management of care, patient with catastrophic disease, during the theory, when you go to the clinical area, you must apply directly and also practice follow by the theory, then practice follow accordingly. So this is all about application of your evidence-based practice. So this is what we call it, this pillar related to the theme just now. These pillars are essential elements that enable the healthcare system to function, because you put there on the workforce. Okay, we talk about the service delivery, health workforce, health information system, access to all this financing and so forth. So this include everything from a well-managed civil service to an extensive communication system. And don't forget community services and integration and the collaboration of all this to give the empowerment for the good healthcare system. So in this healthcare knowledge, because it's changing and also it's always advanced, so we have to keep abreast with the changes. Okay, evidence-based practice is the most we are talking now. Okay, so what I want to stress again, the next slide please. Can we go to the next slide? Okay. Okay, while waiting for the next slide, yeah, care coordination. That is again care coordination because why? We organize dedicated care team. Yeah, we have that organized dedicated care team because that regularly communicate and collaborate on the patient assessment. We have now during the pandemic, we want to ensure the continuity. We have the virtual clinic. The patient will be given the link, and then the patient will meet the doctor and the nurse in charge virtually with this kind of community the collaboration, and also to identify the patient's condition, the status, and with regard to patient assessment, treatment, intervention, and care planning for patient, regardless their level. Because why? What is the most important? There should be a continuity. So all the clinic, what I say now here, most the clinic now, they already have that kind of facilities, so they can always have the virtual what do they follow up if they cannot come, and they also can have the request. So this level of care, also give something up to date. I mean, give the latest, and also to show that we are near to patient's home. I mean, give service next to patient. I mean, near to their home. This is also part of the which is said under the coordination and also under the community involvement. Yeah, because for the purpose, despite of improvement, we still find the significant gap and challenges. However, we still want to improve, because there's a saying goes, what you do today should be better than yesterday. What we're going to do tomorrow should be better than today. So there should be a improvement. Again, the quality guru says the largest room in this world is room for improvement. We want to fill the gap. What's the gap? Is there any exposed gap? Anything the resource regarding the resource, and what are the challenges? So we are here to improve the gap. Okay, we want to improve the gap. So we must also remember, from pandemic now to endemic, what we have done. Okay, what we have done. So this is our concern. Is there any improvement? We must have the feedback. We must have the feedback. So in this management of care, patient with catastrophic disease, remember what you have learned in the theory, you should apply in the practice area. And when you apply in the practice area, you must find the gap. When there's a gap, you must try to improve the gap. Then only there will be a quality improvement. All right, there will be a quality improvement. So that is about the care coordination. Can we go to the next slide? Okay. Again, another slide is on data collection. Why I put the data collection also important, because data can interpret a lot of result for you. Because in the data collection, analytic, and integration, they pull aggregate data from patient electronic health. So that one is under the 6 pillars. When you come to discuss on the 6 pillar of health transformation from the team given, because that data come under service delivery, health workforce, then under health information system. Okay, so that one, number 3 is the 3rd pillar, health information system. Because when to, hello? Time is it?
How more?
No, you can continue still 8 minutes, Prof.
8 minutes. Okay.
Yes.
So when we talk about data collection, this is again, remember, as a nurse, when we have data, we have similar, the subjective data. We have subjective data, we have objective data. Let's say we are speaking under same page. When you study the nursing process in the nursing science, your professional knowledge in the theory, we are speaking all over the world. Nurses, we are speaking under same page. When we talk about nursing process, everyone know what is nursing process, right? You know what is nursing process is assessment. You have to assess. When you assess the patient, you diagnose the patient. When we say the skin integrity, when you say immobility, everybody will be speaking under same language. Indonesian nurses tahu, Malaysian nurses tahu, Thailand no. When we have Australian, UK, when you talk about nursing process, so that is about our quality in our professional knowledge. So we want to apply when we talk about this management of care, patient with this catastrophic, we must understand what is the management of care. What is management? What do we mean by catastrophic? What do you mean by standard of care? Everybody must speak the same, then only we can do the best. And everybody speaking under the same category, with same page under this 6 pillar, because the theme for this conference is under 6 pillar. So the nurse will know on the assessment, then she will diagnose the patient, then she will plan, do the plan, and she will come up with a smart plan, specific, achievable, realistic, yeah, and realistic and time frame within that. That is all we speaking the same. We are doing the same, and we want to apply this in the achieving the goal. So after the plan, we implement. Implementation may be a bit different according to the situation, but we are still apply to the same concept of nursing process. Then later, we will evaluate. Bermaksud, we already assess, we already have the nursing diagnosis on our patient management of care, then we do our planning, we will do the implementation, and finally we will evaluate. So everybody speaking the same language. When we talk about this, then we meet the objective. When we meet the objective, now we have the data collection, we have analytic and integration. And we'll pull and aggregate data from patients' electronic health record. So we can read, we can understand, because we are speaking under the same language. Okay, even we are not English speaking, but the content stay the same, right? Kita belajar bersama, same. When you study the uterus, itu rahim, the pear shape, is it? Okay, what is the weight of the uterus? Everybody will learn the same. That is the common and the same terminology. So now we claim data and other source. We use this analytic software to sort through relevant data that can identify patient who could most benefit from care management. When we talk that, we relate to because I want to relate to the health information system with regard to the 6 pillar in the conference. So we must have a good health information system, and from there, that management of care for this type of patient, we have come out with the data, then we can find our solution, because including those with whether they chronic disease or high risk, all this is related to what we are talking about. Yeah, okay. So now this pandemic, as we know,
Of course, they have increased the mobility and mortality, but now we have to come out with our knowledge gap. We have to come out with our evaluation. Then the important the one we know, sometimes pandemic that one cause sudden. Then there's mobility, mortality, as well as social that been discussed earlier by the other speaker, how the political, economic disruption and so forth. And just now I like our guest just now talk about why some do not want to wear mask and all this. Some because they said cannot see the beautiness and so forth. But that is the rule they have to follow that. But now it's a bit relaxed. We don't have to put on mask. We still can can go out, can meet the crowd. In the crowd, so they advise us to put mask. So whatever regulation, the guideline we have to follow during the pandemic. So this is what the world has endured several notable pandemic. Then we also understand because each type require their own preparedness and also response strategy. So however, we have to be aware and be focused, and we must follow for betterment. Yeah, okay. So this is about the management of care, management of care of this patient with the catastrophic disease. Can we go to the next one?
Excuse
I
me,
think-
Prof. 2
yeah.
minutes left. Sorry.
How many minutes more?
2 minutes.
Okay.
Okay.
So in that case, I go quickly. We have to make the decision to support. We have to educate provider, clinician, and staff about how to talk to patient about all this, because health education is very important. Yeah. Okay. So next one, please. Next one, because 2 minutes. Next slide, please. In the conclusion, next slide, I have something to share, because in the care management has emerged as a leading practice-based strategy for managing the health of population with complex or chronic medical condition. So by incorporating system, science, information technology, and encouragement, care management program can raise the quality of care. So with that, I just would like to give my last word, my message here. We have to work together. We have to work together to meet that target. As the saying goes, if you want to go fast, you go alone. But if you want to go far, we go together. So in this nursing fraternity, we as the healthcare provider, we must continue learning. We have to learn. We have to unlearn and relearn. With that note, I thank you for your attention. Wassalamualaikum warahmatullahi wabarakatuh. So the next slide.
Waalaikumsalam.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you. Yeah.
Okay, thank you, Prof. Zahra, already present for 30 minutes with the topic management of care patient with catastrophic disease. And now we invite Mr. Ardi. Mr. Ardi.
Kita ora yo, masuk ahli mau kata puter apa?
Please mute. Sorry. Hello. Okay. Next step, Mr. Ardi, I invite you to present, and Mr. Ardi will present the topic about community empowerment and anticipating readiness to face emerging and catastrophic disease. Time for you for 20 minutes, please, Pak Adi.
Okay, thank you, Ms. Insia. The community, let me to show my slide by myself. The committee, I cannot show my slide. Can you allow me? Miss Insia,
Yes, Pak Adi.
I have not been allowed to
Okay,
show
hello.
my PowerPoint.
Committee, please you share screen for the topic of Pak Adi.
I'm sorry. I would like to show by myself. So,
Oh, okay, thank
yeah.
you. Okay, please, Pak Adi.
But until now, the committee have not already allowed me to show my PowerPoint.
Hello, committee. Please show the PowerPoint of Pak Adi.
Please point me to be.
Okay. Yes. Okay, please.
I'm
Pak Adi.
sorry. I'm sorry, committee. I would like to show by myself.
Please give access to Pak Adi.
Yeah.
To share screen.
Give me allow to.
Please allow Pak Adi to be co-host committee, please.
Yeah, thank you. Okay, thank you the committee. Thank you, Ms. Insia. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. First of all, I would like to thanks to the scientific meeting of International Nursing Conference 6 from the School of Nursing, Surakarta Health Polytechnic, that already give me the opportunity to share my material or my themes. Okay, and this occasion, I would like to share the material related to the community empowerment in anticipating readiness to face emerging and catastrophic disease. Okay, let me start. As we know that in the recent years, so many diseases emerge in this global situation, including in Indonesia. So there are the emerging infectious disease and also the catastrophic disease that can increase the international and national problem actually. Okay, we start with the fact of emerging infectious disease. Okay, Pak Randy, Mr. Randy, in the previous session has already explained the example of disease that included in the emerging infectious disease. Okay, from severe acute respiratory syndrome or SARS to avian influenza that have already emerged in the world and including also in Indonesia, the 21st century has seen the emergence of many new diseases, which have attracted the attention of many people. This disease called emerging infectious disease, or we can abbreviate at AIDS. Okay. Emerging infectious disease are of particular concern to the public health. Okay. Not only because this disease can cause death in large number of people, of community, but also it is carrying a huge social and economic impact in today's interconnected world. For example, these two years, the COVID-19 emerging in the world, including in Indonesia, how many budget that already buying to this situation, and it can increasing the global or the social problem and more. In addition, the impact of this new infectious disease is relatively AIDS have emerged. Asia unfortunately. It's
Excuse
often
me,
the
Pak Adi. Excuse
Sorry?
me, Pak Adi.
Yeah.
Sorry, I disturb you. Sorry, because this is Mrs. Abigail already connect in this meeting. I'm so sorry. Is it okay if we stop first and we give chance to Mrs. Abigail? Sorry,
understand.
sorry for this inconvenience.
Yeah. No
Okay.
worries. No worries.
Okay,
It's okay.
sorry for this
No worries.
inconvenience.
It's
Okay.
okay.
Hello, Mrs. Abigail. Hello.
It's fine for Adi to carry on. We can go after. That's fine.
Is it okay? This is great.
Yeah, that's fine with us.
Okay, sorry, because this is because different time maybe, so sometimes this a little bit different to make sure. Okay, if okay, just welcome to this meeting, and we will give you time after Pak Adi finish presentation. Okay, thank you very much for Mr. Green, and Pak Adi, please you can continue first for your presentation, and then continue by Mrs. Green.
Okay, thank you very much, Miss Insia. Okay, the emerging infectious disease, emerging in Asia. Unfortunately, Asia is often the epicenter of this condition, including Indonesia. Emerging infectious diseases are diseases that appear and attack a population for the first time, and then or have existed before but are increasing very rapidly, either in terms of the number of new cases in a population or their spread to new geographic area. Also, group in emerging infectious diseases are diseases that have occurred in an area in the past, then declined or have been controlled, but then reported again in increasing number. It is like a dynamic condition, fluctuate. Sometimes an old disease appears in new clinical form, which can be more severe or fatal. This disease is called re-emerging disease, that most recent example. And then in the fact that about 60 of infectious diseases in humans have been recognized, and about 75% of the emerging infectious disease. Okay, this is the first condition that seem of our country at this time. And then the second condition, the second problem is catastrophic disease. And particularly, the catastrophic disease is also can be called as the non-communicable disease. Yeah. And the non-communicable disease behavioral risk factor also contribute for increasing morbidity. Based on the National Health Surveys a few years ago in Indonesia, reported that Indonesian behavioral risk factor of non-communicable disease consists of unhealthy diet, and then smoking, physical inactivity, and mental emotional disorders. The highest prevalence of non-communicable disease risk factor is eating less vegetable and fruit. It is very data that the people that highest prevalence of non-communicable disease risk factor is eating less vegetable and fruit until 93.6%. Okay. Based on the both of the problem in Indonesia, up to now, our government by the Ministry of Health of the Republic of Indonesia is committed to implement health system transformation there are 6 pillars of the health transformation. The first pillars of the primary care transformation, actually. Now, this is very important. Why? Because in the primary care of transformation, it have to be supported by the community, by the activity of community, by the awareness of community, and the hard staff of the government civil servant can support the community to gain the 1 pillars of the health system transformation, actually. Okay, there are 4 there are 4 strategy in the primary care of transformation. First of all is population education, and the second is primary prevention. The third one is secondary prevention, and the fourth one is improving capacity and capability of primary care. We will start with the population education. So the education is very important. Why? Because the community can enhance so many problems by themselves when they have the well education. So as a nurse, as a staff of the medical team, we have the capability to educate our community in our environment, actually. Okay. Emerging infectious disease and catastrophic diseases are very dangerous and can threaten national security. Both types of diseases are basically preventable. So the community empowerment is very important in this situation. And also the community is the main key as actors in preventing the occurrence of this disease condition. Okay, come back to the first pillars of the health system transformation in Indonesia. The second one is primary prevention. Prevention is better than curation, actually, curing. So the prevention is primary in the section of the community. So we have increased the community empowerment to gain the successfully of the health system transformation. So actually all of the strategy in the first pillars of health system transformation is the key is in the community empowerment, actually. This is the regulation of the community empowerment in health sectors in Indonesia. Community-based health efforts, and after abbreviate as a community vehicle empowerment in the health sector on the basis of community need, and then managed by, from, for, and with the community, with the development of the health sector across sectors and other relevant stakeholders. How can we implement this community empowerment program in Indonesia? Okay. To answer health problem that occur in community, the government sometimes ago has issued a policy on the Desa Siaga program. We call Desa Siaga. Desa Siaga is the preparedness community condition in one village. Why we start with village? Because the village is the smallest community, that is government in Indonesia. This is village. So the government a few years ago issued this program as the first program to push, to support the community empowerment. Who can implement of the Desa Siaga actually? In Indonesia, we call PKMD, Pembangunan Kesehatan Masyarakat Desa. This is the development of the health community in the every village. And how can the nurse can effort this program? In every community center or puskesmas, there are some nurses that has the duty to support the community in a specific area. So the nurse can effort their own community in their environment to increase their empowerment actually in health sectors. Okay. As previous I said before that the running program of the program Desa Siaga is PKMD, Pembangunan Kesehatan Masyarakat Desa, Village Health Community Development. There are 4 steps in the development program. First of all is discussion among the community itself. And then the second one is community survey. And then the third one is discussion too. And then 4th step is implementation actually. What happened in the first discussion? So the hard stop in the public center can invite the community to discuss their health problem in their environment. The community is invited to be able to identify health problem in their environment. Next, the community is invited to analyze the priority health problem they face together. Okay, so who will conduct the survey? Actually, the conduct the survey is community itself. Why? Because this is the community independent program. We can increase their effort to think that the problem is emerged in their area, in their environment. And they have to responsible to solve this problem by themselves, by the community self. So this is the main of community empowerment. And we have applied in Indonesia. Okay. If the community is aware of the health problems that occur in their area, the health officer then assists them to determine priorities for handling the problem. So how can conduct the priority intervention? Community
Excuse me, Pak
itself.
Adi.
Sorry?
Yes, your time is 2 minutes left.
Okay, thank you very much. Together with the assistance of health workers, the community carries out the activity together in solving their problem. Okay, for example, if a risk factors for dengue fever is found in an area, we invited the community to find out how to identify mosquito larvae. Yeah. And finally, we encourage the community to independently carry out cleaning of places that are at risk of mosquito nets. In the end, if people are diligent in cleaning places that are at risk of becoming mosquito nests, then people will be spared from dengue fever. Okay, this is the example of the implementation of community empowerment. Okay, this is the fact that Indonesia is success to increase the community community empowerment in the health sector. For example, in tuberculosis problem, yeah. If family member has TB disease, another healthy member must be guided to become a drug-taking supervisors. Yeah, this is an example of the success of community empowerment in Indonesia to reduce the dropout rate for TB treatment. And then another example, we can state this is Jumante program, Juru Pemantau Jentik. In Indonesia, we call Juru Pemantau Jentik. This is the supervisor. This is the observer of the mosquito larva. Okay, it can be done by community itself, but before it, the community health worker, especially nurses, teach them how to monitor the mosquito larva and then how to handling this problem and so on. We call the volunteer is health cadre or kader kesehatan. So this is success in Indonesia. And the emerging of COVID-19, we also maintaining the community empowerment to handle the COVID-19 pandemic in Indonesia, especially in Central Java. We call Jogotongo. We observe, we friend of the neighbor to increase the awareness for handling the COVID-19. Okay, so please also, this is the important thing. How can we can run the community empowerment, and we can increase the capability of the public figure, and also we have already educated the volunteers as kader kesehatan or health carers and so on. So we can maintain the community empowerment that can solve their health problem by themselves. I think it's enough, Miss Insia. Thank you very much. And Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Pak Adi. Yes, applause to Pak Adi. Pak Adi already gave speech for around 20 minutes with the topic community empowerment in anticipating readiness for face emerging and catastrophic disease. And now already joined with us, Mr. Abigail K. Green from England. She is Assistant Professor of Simulation Heart, and she will be the third speaker for this session. This is the last session, Mrs. Green. And before we start, I will read the simple curriculum vitae about her education. She passed from Bachelor of Nursing with honor, Nutrition and Dietetics, and then continue with Master of Science Advanced Dietetic Practice. And then she is our HCPC Registered Dietitian, Associate Fellow of the Higher Education Academic, School of Nursing, Midwifery and Health, Faculty of Health and Life Science, University of Coventry, England. You have 30 minutes for presentation, and then after you finish your presentation, we will discuss together with 3 speakers in this afternoon. Okay, Mrs. Green, this is time for you for 30 minutes.
Okay, that's brilliant. I think you have made me a host, so I should be able to share my slides. Is that correct? Or is there anything else that needs to, I can give it a go and see if I can share them. And I also have my colleague with me, Andy Winter. So I don't know if you're able to make him a co-host as well.
Okay.
Can you see my slides okay?
Yes, yes, already
Yeah.
clear for us. Okay.
It's not in display mode at the minute. Abby.
It's not in display mode.
No, we can see the notes.
Okay. Let me try again. I've shared the sound. Okay, hold on a minute. Is it still the same, Andy?
Yeah, it's not showing in slide presentation mode. It's just in editing mode.
Okay, I'm not sure. Let me go to
Bottom left-hand corner. Give that a try. Oh, sorry, bottom right-hand corner.
Do you have the slides open as well, Andy?
Yeah.
Do you want to share it? Because I don't know what I'm putting it in slideshow mode, but it doesn't seem to be doing it. I'm not sure.
No,
why.
sure. Give me 2 seconds. Sorry, could you make, sorry, would it be possible to make me able to share screen, please? Yeah, okay, thank you very much. How's that?
Same problem for some reason, Andy. I can
Right,
see
okay.
notes as
Bear
well.
with
I just put mine into slideshow mode, but I don't know why it wasn't working.
How's that?
It's not loaded yet, but it looks promising.
It says it's paused. 1 second. Anything? Or there we go. Resume share.
It's gone back to our slides with the notes underneath it.
How about that? No difference?
No.
Bear with, Carl. Bear with. Won't be a second. Sorry about
Apologies
this.
about this. Normally it's a straightforward process, so I'm sure we'll get it sorted in a second.
How's
Okay,
that?
clear enough, I think.
Yeah, that's much
Yes.
better, Andy.
Okay.
Okay, cool. Got it.
So I think you might be in control, Andy. So if I just say next slide, would that be okay?
We can do our best, Chris.
Yeah, okay. All right, so thank you very much for inviting us to come and speak at your 6th International Nursing Conference. We're delighted to be here. As Insia did a great introduction, my name is Abby Green. I'm Assistant Professor in Health Simulation at Coventry University. I'm part of the simulation team. And I've got Andy Winter here with me as well. He was Assistant Professor in Health Simulation within the Coventry University simulation team. So we would like to spend the 30 minutes that we have with you to talk about, really, our topic is preparing the national health system for facing emerging and catastrophic diseases through education transformation. And we'd really like to focus on what role could virtual simulated placements have across Indonesia in preparing the national health system for what the future of healthcare might look like. So we're going to share sort of our experience of virtual simulated placements from Coventry University and our experience of developing a virtual simulated placement across Indonesia, which some of you may be aware of. You may have been involved in the development, you may have taken part as a learner in that project. We'd also like to practice a bit of our Bahasa. So I'm going to Sulamat Suri. Good afternoon. And next slide, please, Andy. It was good. Thumbs up. Okay. So overview of what we'll be talking about. So firstly, we'll start with, well, what are virtual simulated placements? So Andy and I use the acronym VSP all the time, but virtual simulated placements might be something that's a new concept for you. So we're going to start with going through, what do we mean by that? What might they look like? We're then going to do an overview of what the Indonesia virtual simulated placement looked like, the project that Andy, myself, and our colleague Natasha in the simulation team worked on. And Andy will tell you lots more about that. We'd also like to talk about some of the learner feedback that we got on the Indonesia virtual simulated placement. And I think the key part to wrap it up is to talk about the future of the Indonesia virtual simulated placement. How do we see that developing in the future? How could that be used or adapted for facing emerging and catastrophic diseases? So we're going to look at, what does the future hold? Next slide, please, Andy. Thank you.
Virtual simulation is the use of browser.
So we're just going to use some of our simulation resources that we have at Coventry University that we use within virtual simulated placement. And I'm just going to let these patient avatars tell you a bit more about what virtual simulation is.
Virtual simulation is the use of browser-based virtual environments such as this one, to create lifelike and challenging situations and simulate patients and healthcare colleagues. In simple terms, virtual simulation is any simulation that requires a screen.
Thank you. Next slide.
You happy for me to go ahead?
Yeah, I just think there's a bit of background noise, isn't there? I don't know if someone can mute, if they have rights to mute the person that has the noise. Okay, yeah, perfect. Thanks, Andy.
Virtual simulated placement is the use of virtual simulation to develop learners' proficiency and capabilities. Virtual simulated placement is therefore placement that is simulated and can be accessed via a screen, for example, smartphone, tablet, laptop, desktop, VR headset, etc.
Okay, that's brilliant. Thanks, Andy. So essentially, virtual simulated placements is anything that requires the learner to use a screen. So as our avatars have just spoken about, it's creating a virtual environment via a browser-based that the learner can access via a screen and work through. So we're developing real-life situations, clinical scenarios, real-life patients, real-life healthcare professionals that they have to interact with, work through certain tasks, and that will help them develop the capabilities and proficiencies that they need within their job role. So hopefully that's given you a bit more of an idea about what we mean by this phrase virtual simulated placement. And we do have a slide to show you a little bit about what the Indonesia virtual simulated placement looks like as well, so that hopefully that gives you a bit more of an idea of what we're talking about. But I also wanted to touch on, why are we looking at virtual simulated placements now? So evidence suggests that a simulated environment can better equip nursing and allied health professional students for practice. And again, I will touch on some of the reasons why this might be as we move through some of the slides. And for us at Coventry University, the concept of VSPs, it definitely was brought forward by the COVID-19 pandemic. So when we're talking about facing emerging and catastrophic diseases, we had to change how we delivered our education during the COVID-19 pandemic, and VSPs allowed us to still continue, allow our students to learn, develop the capabilities and proficiencies they needed to be a qualified nurse. But obviously with the pandemic, they couldn't necessarily go out into practice. So it definitely drove forward our development of VSPs. But as we all know, technology is advancing. And due to the increase in access to technology, we need to map that into how we're delivering our education as well. Thank you, Andy. Next slide, please. So when I spoke about there is evidence that a simulated environment can also or be better prepare students for practice. Some of the advantages of VSPs that we have found as an educational resource to prepare for future of nursing training is VSPs, we can reflect the fast pace of healthcare. So if there's something in the healthcare setting, there's a new emerging or catastrophic disease, we need to train up nurses to be able to manage that condition. So an example might be COVID-19 pandemic and the use of personal protective equipment. We could develop a scenario where they have to work through that scenario, they have to read about PPE, and so we can reflect the fast pace of healthcare. We can adapt the scenarios to anything, and we can make sure we're keeping up to date with how quick healthcare moves and education that is needed. The VSPs can be rolled out across large groups of people as well. So for our Indonesia VSP, I think we ended up having about 171 learners across 30 plus polytechnics across Indonesia. So we can develop this scenario and we can roll that out to large groups of people. So it's an effective way of providing an educational resource to lots of people that need it. They are replicable and they can help the learner to build confidence. So they also provide an equity of access. So we know that all learners are exposed to the same scenario, which they might not always see when they're out in practice in the real world. But it might be something that is very essential that they know how to manage this condition because they are going to come across it in their career. But they might not always get a chance to see that in the real world, when they're on placement. So it's something that can augment their experience, so add to their learning that they already have, that can add to the experience that they might have out in practice. And it's a safe environment, so they can make mistakes and they can learn from those. And it has helped us to overcome some ethical issues as well that I think Andy will touch on later. So Andy, next slide, please. So this last slide, if you could play that for me, Andy, is just to show you what the Indonesia VSP looked like. So we made this virtual environment to be as real life as possible. So the learners have a patient scenario. They had 4 patient scenarios. This is one of them. So they can see an image, imagine what that patient looks like. They had an S-bar, so they could look at the situation, background, assessment, recommendation. They had that in English and Indonesian. And we can also do things where we can embed certain resources within that.
So worried about me. I think he went paler than me when he said I was worried about my heart.
So we can also bring the patient to life by giving them a voice. We can allow the learner to hear what the patient has to say. And as I mentioned previously, we can also embed different resources within the virtual simulated placement as well. So if there's a specific, for example, we had a video, I think it was from one of the polytechnics about log rolls in Bahasa. So if that's a resource that you need to get out to lots of people to train them up for the virtual simulated placement.
Oh, he's so worried about me.
Apologies for that, Abby, back to you, or do you want me to take over from here?
Oh, yeah, I think yours is the next slide, isn't it?
Apologies, sorry, I thought I'd
Yeah,
cut you off.
that's fine.
Sorry. Okay, well, let's not start that again. Let's move forward. Okay, so Sulamat Sari, I think that's my best attempt at good afternoon in Bahasa. My name is Andy Winter, as Abby has already said, and I'm just going to give you an overview of the Indonesia virtual simulated placement. The way in which we went about, as we do all our virtual simulated placements, is it's through collaboration. So you've met myself and Abby. The lady at the top there is Dr. Natasha Taylor, who was kind of the originator of the idea of the virtual simulated placements. And we did that in conjunction with the FCDO, the Foreign Commonwealth and Development Office. And it was a joint collaboration between ourselves and 37 Polytechers, of which some of you are probably in the audience today. And what we did was we came together over Zoom to basically bring all the experts together. And that's one of the things that's really important about our VSPs is it is all about collaboration, where we from Coventry are kind of like the originators of the idea and know how to put it into practice to deliver the product. And we obviously do offer a wealth of understanding and knowledge in relation to certain fields, and especially regarding a simulation. We can't do this without the help of the people that it's supposed to be for. So therefore, it's worked in conjunction with our colleagues over in Indonesia. So the way in which we delivered this was primarily, well, it was all via Zoom. At no point did we actually meet face to face, which was a shame because it would be lovely to come and visit you, maybe in the future, who knows. But the project itself was actually quite a short turnaround of about 2 months. So in the 2 months, we used a evidence-based plan design template. So it allows us to basically provide you with the information that you need to give us, so therefore we can create the VSP of your choice and delivers for your students and your service users. So as it states there, it took about 2 months. We had to collaborate, design, test, release, and we evaluated that using a JISC online survey, which was completed in 2022. All this, like I say, being done over Zoom, did prove some challenges at times, but I have to say it's something that I know myself and Abby are very, very proud of, and those of you that are involved in the creation of this should be proud that to turn this virtual simulated placement around in such a short period of time with the difficulties of distance and using teleconferencing software was no mean feat. So it was excellent. From a scenarios point of view, it's important that you recognise that we basically wanted to cover all four fields of the nursing. So we covered adult nursing, children, young people's nursing, which we refer to as CYP, mental health and learning disability. All these scenarios were set in an emergency department to provide the parity that your final year students will experience of an emergency department placement. And the type of placements that we had were able to present your students with issues and conditions whereby some may experience it and then some others. So therefore, as Abby has stated, you're getting that parity of experience. All of them were designed in line with regards to the UK Nursing Midwifery Council, so the NMC. This was basically tallied up against the equivalents in Indonesia amongst your with our fellow peers from the Polytechers. Now, effectively, what we did was we matched what you wanted to replicate from the NMC to make your students more international, and also replicate what you have in Indonesia. The benefit that we see massively in relation to your VSPs is this notion of being able to simulate ethical issues, which would be, or not ethical issues, well, sorry, they are ethical issues, but situations that would be unethical to simulate in a real life situation. So for example, one of our simulations is based around a young gentleman, Eric Evans, who presents with suicidal ideation due to the fact that he's got anxiety, depression, and also has an eating disorder. Now, whilst that's not necessarily a rare occurrence, it's quite rare for your students to potentially encounter that interaction or encounter that type of patient. By simulating that in a nice, safe environment, it allows all your students to have that form of experience, and it allows them to apply their learning to a given situation, so therefore they're better prepared for when they actually either qualify or actually do encounter that in practice. The placement that we use clinical learning hours. Now in the UK, for the NMC, it's essential that all students must complete 2,600 learning hours. There is, I believe it's something similar in Indonesia. Our VSPs are able to genuinely condense a certain amount of learning and produce and award the students with a certain amount of clinical learning hours. For example, one of the things that we often see here in the UK is students will go on a placement and they'll say that placement they've been on, they don't feel as they've learned anything. The issue there is the fact that they will still see it as a bonus because they've had X amount of hours removed off the total that they need to achieve by the time they qualify. But that potentially could be seen as wasted learning hours. Not to say that VSPs need to replace placements, because they shouldn't, but what they can do is 100% augment and enhance the learning from certain topics surrounding that. Sorry, Abby, back to you.
Oh, yeah, I can't. Oh, yeah, the slide just went. I've got the slide. It's fine. Thank you.
Cool.
Yeah, so just in terms of some learner feedback. So as of the end of March, we had enrolled 171 final year nursing programme learners onto the Indonesia VSP. Those were all clinical scenarios based in an emergency department. And on average, that equates to around 6 learners from 30 polytechnics across Indonesia. We did an online survey, and based on the response rate that we had of about 30% of those learners, we had an overwhelming positive response of 82% of respondents being satisfied with the quality of the VSP. Andy, if you could show the next slide, please. And this is just to give you some of the key things that came through from the qualitative data that we collected from the learners. So the key things were that they felt the VSP mimicked real life scenarios. They allowed them to develop their critical thinking around the case study or the scenario. It was great experience before practice placement, encouraged them to think, to do deeper learning around the scenario, really take time to think about what they would do in that situation, should they be faced with that in real life. So thank you, Andy. Next slide.
Okay, so we've gone over what a VSP is, so hopefully you've got a very, very good understanding as to what our virtual simulated placements are, what it's like in relation to the one that we created for the Indonesian Polytechers. But you're probably starting to wonder, how does this relate to today's talk about the emerging and catastrophic diseases? Essentially, it's this, is we don't know what the future holds. We've got no idea. In 2015, there was a question that was asked at most interviews. In 5 years, where do you see yourself? Not one person got that question right, because no one understood that 5 years later, so 2020, we'd all be sat in our rooms staring at a computer like we're doing now and learning in a completely changed and different world. We have no idea what the future is going to hold, or we have some idea. We don't know what the next thing is coming down the line. We could be facing some form of climate emergency. Well, we are facing a climate emergency that's going to get worse. We may see environmental disasters such as tsunamis. We may see issues relating to a further pandemic. There could be earthquakes, tsunamis, war. We don't know. Bottom line is we need to be prepared. And by preparing for the worst, potentially we can protect ourselves. So therefore, if we're ever locked in our rooms again, teaching and learning via a computer, we have the means to essentially have business as it continues, keep the business continuity moving, making sure that we can deliver a deliver a good educational experience to our students to allow them to progress through their training. Because should any of these things happen again, we need more healthcare staff worldwide. There's no, that is just a fact. And to do that, we need to make sure that they're trained, and we have to make sure we've got some form of what we like to refer to as a digital safety net. So we work on the principle of planning for the worst and hoping for the best. The notion here is that I've gone quite extreme in the sense of talking about, say, another pandemic or, a conflict or something that could potentially impact the way in which we currently teach and educate our students. But if you think about it from this point of view, the VSP can be seen there as a safety net. A student may not be able to go out onto placement for some reason. The placement may fall through. If you're able to catch that student and provide them an experience of parity in relation to the experiences that their colleagues that are out in practice may get, then surely that has to be a good thing, because it's going to keep everybody moving forward. It's not all bad. One of the benefits that we've seen in relation to this notion of distance learning is the advent of using different technologies, and technology is always moving forward in a quite advanced format. And it's what we're starting to see, and what you can see on screen at the minute is we kind of go from clockwise right to left. On the left here, we've got one of our new pregnant avatars. These are AI avatars that we're hoping to embed within our virtual simulated placements going forward. So it'll be a lot more interactive. The next image is again using the same system, the AI avatars, but this is actually using virtual reality, using a headset. Going across, we're actually investigating and looking at the use of mixed realities or augmented reality, whereby we can actually put a holographic patient into a classroom, as you can see here, and therefore you can then actually have a patient that you can interact with, and it's a simulated patient to allow for the the less ethical of issues. So, for example, this gentleman here, it's not possible to get someone who has have an MI and just get anybody off the streets having an MI. We can simulate it in a worthwhile way. Again, we're now also looking at the use of teaching A&P digitally from a distance point of view using augmented reality. The lower image was actually taken from this very room that I'm in, whereby we were taught about the immune system, the vascular system in relation to a human body, and that was done from a classroom based in Sydney, Australia, and we're here in the UK. In conclusion, we firmly believe that VSPs are a meaningful way to enhance the exposure to experiences that are not always guaranteed. It's really crucial to understand that, is that by providing that and learning from the different experiences that others have and we've had, we can replicate almost anything to a degree, and therefore increase that parity of experience and students' learning experience. The blended nature and reflective nature of our VSPs allows for better understanding. And ultimately, as it shows here from a reflection point of view, it's going to open new doors to innovative methods and educating for healthcare professionals in the future. Terima kasih telah mendengarkan. I think that might be right. We'd like to thank you for listening, both Abby and I. Also like to make a point of saying that we did this through a commission with the SCDO for the Indonesia Polytechers, and we are very, very keen to do further work with you and anybody who would be interested in that. Please do contact us. We'd be very, very happy to meet with you in relation to this. Abby, is there anything you'd like to say?
No, I think we're just, if anyone has any, dependent on time, any questions, we're happy to take questions. But yeah, please contact us if you'd like to be involved with developing VSPs.
I'm going to stop sharing because I can't see any videos at the minute. There we go.
Okay, thank you very much. Applause for Ms. Green and Mr. Winter. Really interesting topic, and we become wow. And we just imagine for next time for future nursing, especially in Health Polytechnic of Surakarta. Okay, thank you very much for your presentation. And now we come to the discussion, and we have around 10 minutes with 3 or 4 speakers here, Professor Zahra, and then Mr. Adi, and Ms. Green, and Mr. Winter. And now please give a question for all speakers here. And during we wait for the question, this is already the question in chat room. I will tell you, Pak Adi, already one question for you from Dharma Putra. From Dharma Putra, the question is, what should we do when in the remote area, the pillar of health transformation isn't going properly? This is question for you, Pak Adi, and we still wait for the question for other speakers.
Okay, thank you very much. Mr. Dharma Putra Fauzi, thank you for the questions. Actually, the transformation program in Indonesia will run as soon as possible. The important thing that the transformation is government will allocate the special budget to run this program, and then so many so many strategy to success 6 pillars. And don't worry about the condition of rural area or remote area, because one of the pillar is government will increase the hard worker, both in quality and quantity, both in quality and quantity, especially to gain the number of doctors and doctor specialists. And also in the primary care pillars, in the first 5 pillars, government will increase the development of the number of community center, as we know that today there is like a number of community center. So when the government will run this health transformation, government will increase the number of community center with the adding of some facilities like a laboratory and some services in this new adding of community service. I think this is my question for Ms. Dharma Putra Bu Insia. Thank you. Bu In, I can hear your voice.
Okay,
Yeah.
sorry. Thank you, Pak Adi. And Dharma Putra, already clear for you the answer from Pak Adi. Okay, yes, thank you. Already in chat room. Okay, and then is there any other question for Mr. Winter, Ms. Green, and Ibu Zahra, Prof. Zahra? Okay, this is also, there is question for Prof. Zahra, especially for this situation now. The situation already moved from pandemic to endemic. And what is the difference between the clinical placement, especially for students in Malaysia, especially in Masa? How the academic manage for this situation?
Okay, thank you for the question. During pandemic, the clinical attachment of the student, they were given restriction. So the student during the early part of the pandemic, the hospital and other clinic placement of these places, the restricted, meaning that they reduced. We used to send from the ratio given, the number is 1 to 8. 1 to 8. That means 1 clinical to 8 student. During the pandemic, they reduced to 1 to 4 in order to follow the regulation SOP. And some of the area we can send our student. So the situation now, the practice, they reduce the number of the student. After the pandemic, they try to, gradually improve the ratio as before. At the moment, we still maintain the ratio as given the guideline by the regulator body, meaning that the Nursing Board of Malaysia has given us permission to go, but the number of the students will be limited, not to send as usual the number. So 1 to 4 in the open ward, and the rest as usual, we have to maintain the number. We cannot send more than 4. According to the guideline. Before we used to send 1 to 8. in the open ward. Now they reduced to 1 to 4. So that is a practice. And some of the places like in the community, we are trying to reduce the duration. We used to send up to 4 weeks. Now they allowed, we can send to 2 weeks placement instead of 4 weeks. All because we want to reduce the crowdness, also follow the SOP, the new SOP. Then I agree with Abby and Andy. The simulation practice is very good. We also adopted the simulation in the scale lab. We have the simulation ward, so the student can practice in the simulation ward in order to acquire their nursing skills. So that is my answer. Thank you.
Okay, thank you, Prof. Zahra. Okay, can we stop for a moment? Sorry. It's done for Asar. I'm so sorry. And we wait for the question from chat room. Okay, we can continue now. And in the chat room already there is a question for Mr. Winter and Miss Green. I will read for you. I'm Fadila from Health Polytechnic of Surakarta. I want to ask to Mr. Winter and Mrs. Green. And the question is, can we see the health community as the indicator of the successful of health program of some disease? Is it still appropriate for your topic? But this is question for you. And please answer the question.
I think neither Abby or I are epidemiologists, so I think we're not best placed to respond to that question, unfortunately. Sorry.
Okay, sorry. This is about the material is about prepare for future of nursing training through virtual simulated placement. Is that right? Yes. Okay. This is a question, but not in the chat room, but just send me the SMS. The question is, actually, I follow this meeting, but I'm still not clear about this. This is the question. Is it like the project to prepare a nursing student for clinical placement, or this is like replacement, or like preparing for students who cannot follow the placement as catastrophic disease? This is the question. Is it clear for you?
Yeah, I'm assuming that's a question for Andy and myself. Is that correct? Yeah.
Okay.
Yeah, so the virtual simulated placement is used to augment that clinical placement experience. So we would still very much want that learner to go out into the physical real world and have the experience there. But it can be used to provide a bit of placement preparation. So before they go out on placement, perhaps, or add to what they might see on placement. So if there's, if you want them to do a mental health scenario, because they may not all get exposure to that, although obviously we know it's very common, so most probably they will see that. But if there's something that you want to make sure every learner within your polytechnic has exposure to, it could be used as a scenario that you develop for that specific situation. I hope that answers the question. So not to replace placement, to prepare or augment, add to the placement experience. And often we would say that those would be, the scenarios that we develop for the virtual simulated placement would be very challenging situations that maybe they wouldn't necessarily see, but they are likely to come across, and they need to be prepared when they do come across it in the real life setting to be able to manage that. So I hope that answers the question.
Okay, really interesting. Okay, thank you very much for our speaker. The time already 2 p.m. past 51. Maybe some of students already hungry about this because so long day from in the morning until now. And thank you very much. Before we finish our meeting, I think I give you time around 1 minute to give conclusion for this meeting. Start from Prof. Zahra. This is time for you, just for conclude. Prof. Zahra, still mute? Sorry. Okay, thank you.
Okay, dear student, this is my message to you. Lifelong learning is our culture. Remember, a nurse who graduates today, stop learning tomorrow, is uneducated the day after. So lifelong learning is our culture. With that, thank you. All the best.
Thank you, Prof. Zahra. Then, Pak Adi, please, it's time for you.
Okay, thank you very much. That community involvement is very important to handling the health problem, because community is the main part and can be play role as the actor of the handling problem of so many cases of the health problem actually. So especially for student, community is very important to be placed to gain the clinical placement for you. So you can go to the community to get some sciences to increase your capability and competencies. I think it's enough, Ms. Insia. Thank you.
Thank you, Mr. Adi. And then next for Mrs. Green and Mr. Winter. It's time for you.
I think the message that we really want to send out to everybody is experience is key. And if we share our experiences, and that's not just the students, that's our the teachers, all those who are doing it. If we share those experiences and learn from those experiences, we can simulate them in a valid and applicable way to enable people to learn from each other's experiences to enable better healthcare professionals. And with regards to Professor Zahra, 100% agree. Lifelong learning is the key. Every day is a school day, we like to say over here. You're on mute, sorry.
Thank you. Thank you very
Thank
much
you.
for all wonderful speaker this afternoon. Thank you for your sharing knowledge and experience for us, for better health condition for us, for students who still learn, start now and then become a nurse next time. And thank you very much for joining in this meeting. And I do apologize when we accompany you during this meeting, maybe so many mistakes. And thank you. And hopefully next time we can meet together in a more interesting moment. Thank you very much. And now I pick the time for Master of Ceremony. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih Bu Insia.
Thank you, Mrs. Insia, Master of Nursing, for getting the fourth plenary session.
Ladies and gentlemen, now we are going to the 06 INC. I'm Melita Ashifa and my partner Ahmad Saifullah of the committee would like to say thank you for all the speakers and audiences for joining our event from the start until the end. To come to very end. I hope you found the presentation on this conference are informative and helpful. Also, we would like to apologize if there's some confusion during. Let us all be guided all things we have learned throughout the conference and be able to influence our future. To all of you, don't forget to complete the COVID-19 health protocol so we able prevent the spreading of COVID-19. Stay safe, stay healthy. See you next time and wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Andy. Maybe. Thank you.
Thank you, everyone.